monitoring exercise that was in September. We collected data just to audit what the county government has been doing in terms of just looking at what is in the budgets and whether it has been implemented on the ground. And we engaged a few of the community monitors from the Nyeri County Budget Coalition, who were able to collect data from 14 health facilities. I'll be outlining the facilities once we present the report. And we just looked at whether these projects that were in the budget documents were implemented and the feeling that the community had regarding the projects that we were monitoring. So far, we have the report, and that is what we are launching today. So I'd like to welcome you for this meeting.
I want to appreciate the work that Heraf is doing. I know we've walked a long journey, especially in terms of the community work. And I always tell guys that every time when I hear of Heraf, I think of issues advocacy. Some time back, I attended a training where I was taught what advocacy is. And to me, the simple understanding of advocacy is that, anything that you're given, a lot of time as healthcare workers, as doctors, we have a tendency to, we like talking in jargon. But you see, the information that you need to give to the next person, the most important thing is to ensure that you package it. Package that information. Don't talk about mortality to people who don't know about mortality. When you want to talk about that people are dying, I attended a meeting whereby someone now is able, if the best way to make people understand issues about mortality, tell them to think of a bus. That when you say that this number of people are dying every day, is like a bus of 45 people crashing every day. That way, if you package it that way, the next person might understand it better. The same way. So, to me, packaging is of essence, and I think Heraf has been trying to do that. And I think that one we are going to approve it through the kind of presentation that we are going to see today. The next bit is about the timing. To me, advocacy, timing is of essence. The information that you have, when do you deliver it? And I always give an example to this, that the best time would have advocated for cancer in terms of policy, in terms of everything, is that at one point, and of course this is not a very good story, you remember there's a time the Ministry of Health was split into two, the medical services and public health. And during that time, unfortunately, the both ministers suffered cancer. So to me, in terms of timing, that was the best time to make sure that the policies go through. It was very easy. It became very emotive. And you remember that's just around the same time that the Cancer Institute was formed. And it's not been very successful. So I think for me, when it comes to advocacy, timing is of essence, packaging is of essence. So I think as we discuss here today, and I'm happy, I've really seen, and I want to recognize him. I've seen Nelson in the house, and he really makes an effort to, we belong to various social media platforms. He makes an effort to ensure that information that we throw, at times you see the information on social media that it's very difficult for the kawaida mwananchi to really understand it. So he makes effort to ensure that he's able to break it down. It's a skill that some of us probably don't have, to break it down and ensure that the next person is able to consume it. So I hope that even as we discuss here today, let's not complicate things. Let's break it down and ensure that it's understandable. As you are aware, we are a pilot county for UHC. We were honored to be selected as a pilot county for UHC by His Excellency the President yesterday, and some of them probably attended. We had a meeting, a stakeholders meeting in Greenville yesterday. And a lot of discussion, very interesting discussion. We even had a panel discussion where we involved the community members. So one of the things that I want to tell you, kindly support the UHC agenda. It's a good agenda. The intention is to ensure that no one is denied health because of their socio-economic status, because of their religion, that all of us, when it comes to health, because it's a human right. And that's what Heraf is all about, that everyone has an equal opportunity. That you don't have to sell your cow. You don't have to attend any harambes anymore, because all these services now are available in the public health facilities, and all of them are available for free. We appreciate when we get another person who looks at what are we doing. It's good when you get that kind of feedback. And that's why I said Heraf made an effort to look at what are we doing in terms of budget, in terms of public participation. I know there's a law that exists on public participation. So there are all these things. And I want to say that for us, when you are doing the ADP, when you are doing the CIDP, there's always all this opportunity. All these documents and the budgets, all of them are done. And when it comes to the implementation, within our facilities, we have committees. We are represented because everyone cannot be involved in this. That's the reason why these guys they sit down and select a committee that represents the interests of the community within the facility.
First of all, I want to thank you all for coming, because it's such an important thing, whatever Heraf is going to give us, and I hope that all of us will be very attentive. Looking back, and every time when we discuss with them about issues of community participation, it becomes our responsibility. Because how many of you here, after learning this, will go back and tell people what they have learned? Very few. Some of you will go back in the hospital. Heraf will pass around. They will say they have never even called us for a meeting for Heraf. But whoever was called didn't communicate to the other one that they were never. And I'm sure the donors might come to assess Heraf as well. It's not only them that are assessed. Now, Pitia Hospital is Zenu. They go to Karatina. The first thing is, Heraf has been working with you. They ask, who is Heraf? So it's important for us to understand that every time when we get something, we give feedback. Another challenge I want to give is even the social media. They only like to do things in WhatsApp. You know, our communities don't have those WhatsApp things. Those things are only for emotional things. How many people look at other methods of communicating to communities? My mom needs to understand issues of health. She's not on WhatsApp. Are you understanding? Yeah. Except emotionally. And that's why I hate all those things. If you put me inside there, I'll get out the same day. So don't even dare try. Because I know they are more emotional. Because the person who needs, especially the public health services, is my mother, that woman there in the village, who does not understand those WhatsApp. All she would understand most likely is an SMS. If you send her an SMS at Asoma, but WhatsApp Hana, what other ways that we can actually use, whether it's dancing, whether it's community barazas, whether it's in church, what other ways can we be able to reach the communities? Because one of the challenges I've had is when we want to reach out to communities, we are not able to reach them. Some of us will throw things in the internet, and also even looking at the government also, which also guides us in terms. They say we throw it in our website. When we throw it in our website, Heraf will go and ask communities, did you know? They say no. But by law, I've met. I mean, I've thrown it in WhatsApp. Yeah. See, I've thrown it. Actually, they can't take me anywhere, even if they want to take me anywhere. Because by law, I've complied. I've thrown it in the Nation, because the Nation is the most circulating paper. The Standard, in my website. How many of the people in the community can reach those websites? As far as I'm concerned, I've complied to the law, but at the end of the day, have I reached Wajiko? No. So it's important for us, even as we discuss here, and community members. And the best thing is to ensure that whatever, when we say we want to reach the community, we use the those basic social things that we can actually be able to reach out to our communities and learn. When we call for community even participation, whom do we call? We call the same guys every day. The same guy who is a busybody, who is from one to the other, and he never tells anybody anything. He goes back. And particularly they will say, when I'm there, the community has heard. Instead, what does he do? He throws it in WhatsApp. WhatsApp is not always the community. And actually, when I look at WhatsApp and you're throwing tantrums, I always imagine, my Wajiko is not in WhatsApp, so I don't even need to be part of you. And therefore, we are very happy that they have come. Let them think ahead as we get our report. How is it that we are going to reach that community that needs to participate in terms of provision of these services as well? And Heraf has been a partner to that. They have helped us in Mukurene. They have even done a customer care. And I think I was even challenging her, why aren't we getting it? It's more important for the health workers to understand what people think of us. As we even interrogate this, there are things that are ethical, that we most likely all of us might have complied, but we need to ask, did we really reach Wajiko? Okay, the auditor will give me a tick, because he will go through the procurement and what the Disposal Act, he ticks. PMF Act, he ticks. But has Wajiko ticked? No. But don't take me anywhere while you're such a, because at the end of the day, he's the one who decides whether I go home or not. But at the end of the day, we have a problem. Because our problem is the government does such beautiful work all the time. But if you ask the communities, what do they say? And why do they say the why? Meaning they are doing nothing. Why do they think we are doing nothing? Information. Because they lack information. Actually, we have to learn to communicate. And a communication that gives people hope, not helplessness. As you look at this report, the report is for projects that were done when? So you guys said you participated. When were these projects implemented? 2015, 2016. So basically, don't look at it like an old project. There are lessons that we can learn from the past. Are you understanding? Yeah. And that's why we came. Some of us would have said, even this government was another government, so it has nothing to tell me. Isn't it? And if all those mistakes were there, they were the Gachagua law. But there are things that we can learn from every mistake we make. Are you understanding? Yeah. So as we live here, let's think, what is it that they did well, and we'll fast track it. What is it that was done wrongly? And remember, the government systems didn't change. There might be the politicians changed. See, the system is the same one. The same one. And therefore, we have to be very careful, even as we make conclusions. And I want to write to those who like throwing water. And you know, the government of today, that was that government. But are we able to address the issues that they addressed? Or else, we'll be blaming one government after another. There's a system, and this system has to work, whether the government was there or not. No. And I'm actually begging them as well. Is it possible also, so that even as we want to be in the scorecard, whether the projects we have done between this time when we came into power, whether they have actually changed. So you need to know whether we are even improving or whether we are still in the 2015, 2016, 2017. Sawa sawa. And I want to thank you for coming. Even the customer care. If you want to present it, please let's not just look at we don't have money. You can use the same forums we have, and we can now invite you to come and give the customer care. Because we want to know, actually I would be more interested to know what people think of us when we are offering services. More interested than all the other. These projects aside, the auditor will either give me qualified or non-qualified or take me to jail. But I want to know, am I really meeting the need of this poor woman who has come for UEC services? And that is we truly appreciate her support. And anyone who is in this, in the community, working with communities, we really would want to partner with you to be able to give hope to our people. Well, we are wrong, tell us. If you think the governor is wrong, walk in his office and tell him, you are wrong, sir. But if you think you're going to get him by throwing him in social media, I think you're wrong. That is what, it might be unless you want to be the next governor. If you want to be the next governor, it's well. It's good competition after all, even if you made it by kusema wengine si wazuri, sivyo? Even though useme ni si mzuri. But if you want to improve this county, and I'm sure I'll give him feedback, I'll tell him that you're here and you're ready to go.
Thank you very much, Dr. Rachel, for the wise words on ensuring that the community is engaged. So I'll just take you right to our program, and you have to start with experience on community engagements, which will be done by Christine. And then I'll take you through the brief highlights of the reports. And then we'll have now comments and interactions on the reports will come after. And then key remarks from guests. We have the CC from Health, and then the Chief Officer Finance and Economic Planning. And then the Auditor General was omitted there, but they are also in the program. And then the report will be launched by the Speaker of the County Assembly. So that we don't waste much time, I would like to invite Christine to take over and make her presentation.
We came here to launch a project on budget monitoring. And now we are talking about UHC, right? Tunashangaa, si ndio? Tunashangaa sasa huyu mnyama ametoka wapi, anafanya nini hapa, na kwa nini, si ndio? Nyeri is a pilot county for UHC, true or false? Yes. Is it ongoing or ni kitu inaongelelewa kwa boardroom? Eh? It's ongoing. How many people have benefited in one way or another? How many? Daktari, waone wenye wataki kutumia huduma zetu. How many of us have benefited? And when we lift our hands up, we lift them above our head.
Who is not a member of UAC?
Who has not registered?
I can register them right away.
Who has not? The platform is here. Usiseme ati sija. How many have not registered? If you are not registered,
ask how many are registered.
Haya, sawa. Wangapi wamekuwa registered? Hata nione mwenye nimeona mmoja. Jen Gatimu naona mkono wake uko chini. We are very compliant. How many of us have the cards? Just one person. Why? Just one person has a card. Why?
Some of our members of community who are away from the facility,
plus
they've not fallen sick. Because maybe the main reason for visiting the facilities when somebody is unwell. Okay. So the cards are just lying there. I would imagine that if we partner well, even the the assistant chiefs, it would be a better forum to distribute those cards rather than having them lumped somewhere.
We had distributed these cards to all the facilities because where the cards are is where you registered as your primary health facility. Kama ulisema ile mahali utakuwa unaanza ni Nyeri Town Health Center, that is where your card is. So that's what I'm saying, and I like that there are community leaders in the house. We are also going to ensure that we pass this message, we are communicated to our community health volunteers, to our in-charges, but be assured that if you know where you registered as your primary health facility, your card is there, you can pick at any time. We also try to talk to Farm Access, see whether they can send a message, because when you are registering, you also give them your phone number, because that is going to be important. But with or without a card, as long as you're in the system, today, if I want to know whether the guys who raised their hands here is true, they were registered, I'll just ask you for your contact or your ID number, and I'll tell you whether it's true or not, you're registered.
Si lazima tutenge forum special just to say the cards are out. Sawa sawa. Si sasa tumekuja hapa tumeelezewa cards ziko. And I witnessed the deputy governor receiving her card, the CEC Health receiving her card. So I can attest that the cards are actually out. So hata sisi tukienda tufanye nini? Tueneze ujumbe. So back to my first question. We said we are coming here to launch a report. Then why UHC? We appreciate that Nyeri is piloting UHC. Sindio? Sindio kweli? And that's why we have issues around cards. That's why we have hizo services zenye tumekuwa tukifanya nini? Tukipata. Sindio? Si huduma ni za bure. I don't like using the word bure. Kwa sababu mtu pahali amefanyia nini? Amegharamia. Ukweli ama uongo? Is it true?
Ni kweli.
Alafu pia ukiambia watu ati services are free, we have the tendency of misusing free services. True or false? Utasema kwa sababu sijalipia, I can as well go to the hospital, get the drugs and just keep it. Nisipopona, si bado nitarudi tu na watanitibu na ni free. Si ni ukweli? So we want to tie what the projects that we have launched to the UHC work that is going on. Because UHC is a project, right? Which is supposed to benefit the citizens. And it is our responsibility as citizens, just as we are launching this report. It's our role to monitor how services are being implemented. Sindio? Si lazima tu ukae useme ati mimi kwa sababu dispensary yangu ni Karafa, sitaenda huko kwa sababu mimi si mgonjwa. How will we know what is going on? Kwa sababu mara mingi tukiwa wagonjwa huwa tunasahau mambo mingi. Ukweli uongo? Unaenda tu hapo unataka udumiwe na mambo ya ishe. But when you are unwell, then you get to know what is going on. Kama Linda Mama inaendelea, inafanya nini? UHC ni huduma gani tunaweza pata? Tuko pamoja? So this is why we are bringing the issue of UHC, and Heraf has been working with the residents of Mkureine sub-county just to sensitize them on what UHC is all about and their role in this. So as we continue receiving these services, lazima tufanye nini? Tuwe makini. County iki-launch project, then we need to know what exactly is it doing and how can I support. Sawa sawa. Because the healthcare system ni system too. It's just a system. So it needs support from all the stakeholders. Ni ukweli? The private sector has a part to play. The citizens have a part to play. Kwa sababu tukipewa huduma and we don't go for them, who will go for them? Hakuna? Sahi naambiwa madawa yako. If you don't go for those medicine, it means they will expire na zitupwe nje. Si ndio? So that is waste of resources. Mara nyingi huwa tunaangalia na tunasema the county, the governor, the CEC, the doctors ndio wana waste resources. But we should ask ourselves as citizens, how are we wasting resources? When a service has been planned for and we don't go for it, that is wastage number 1. Tuko pamoja? So I'll just take you through a brief of what we have done as Heraf with the citizens of Mkureine. And some of the issues that we want to present here today are the concerns that have actually come from the community. And I'm very happy as we look at them, and as I sat at the stakeholders forum yesterday, it replicates across the county. It's not just in Mkureine. I had people talking about it. Issues around sensitization. People don't know that UHC has been rolled out. People don't know why they should register for UHC. And what is the difference between UHC and NHIF? Si wengine wetu tulikuwa tunasema ati kwa sababu niko na UHC mbona niendelee kulipa NHIF. Sijui kama hiyo ilikuwa inafanyika.
We have to convince people that it's proper to continue. With NHIF.
Kwa sababu gani?
To people, they thought UHC had come in the place of NHIF.
UHC unapata huduma wapi? Government? Hospitals. Where?
Health centers and
health centers, dispensary, level 4, level 5. Ukibeba kadi yako uende nayo Nairobi, kadi yako ya UHC, itakusaidia? Haitakusaidia. Kwa sababu gani? It has not yet started. Yeah. Alafu nasikia pia naambiwa ati it is the county where you are enrolled or registered, na pia you have to start from, it's a gradual process, si ndio?
Yes.
Si ndio? Ni gradual process, mdogo mdogo. So, the reason as to why you need to continue paying for your NHIF is because one, leo unaweza kuwa mgonjwa. Mimi sasa unajua nikiwa mgonjwa nitakuwa na nini? Benefit sana. Niko Nyeri na kuna UHC nitasaviwa, nitahudumiwa.
Kama uko registered.
Kama niko registered. So when you go outside your registered area, it means you cannot get services. Na hapa ndio NHIF card inakuja nini inaingilia. Sawa sawa. Because you can go to any facility and tell them, I am a member of NHIF and I am unwell. Tuko pamoja? So I bet a lot of you know who Heraf is because we've worked with you for some years now. So I won't talk about that. And these are just the key areas, our areas of focus as we work. What exactly do we look at? So we look at empowering citizens, we look at issues around advocacy, and Dr. Mureo has really talked about that. Then we look at increased citizen participation in county and national government planning and budget making process. And that's why we are here today, right? And finally, we are looking at issues around social accountability. Dr. Kamau asked about the patient, the client satisfaction survey. So those are issues around social accountability. Tuko pamoja. So the UHC project that we are running is a 12-month project. It started in October last year. We expect it to run up to sometime in September this year. And it has been supported by Christian Aid. We are working in 8 facilities in Mkureine sub-county. So facility 1 is Njokeine, we have Tambaya, we have Mihoti, Mkureine level 4, Gumba, Kahara, Karafa, and Kil. So the overall objective of this project is to promote meaningful citizens' participation in the UHC discussion. So hapa tuko na few keywords. What is citizen participation? Now how can we qualify this term meaningful? Sawa sawa. What is meaningful? So these are some of the things that we are looking at. So number 1, the specific objective is to promote inclusivity. Number 2 is issues around resourcing. We are looking at monitoring of services, delivering of UHC. And number 4 is we are just looking at how are these voices coming from the community to the national level, to the regional level. Because UHC, one, it's not a new thing. It's a discussion that has been going on. Si kuna wakati tulikuwa tunaenda hospitali tunalipa 20 shillings ya card. Ikatolewa, si ndio? Kidogo kidogo wamama wetu walikuwa wakienda kuzaa wanafanya nini? Wanalipishwa. Ikatolewa. Siku hizi hata kuna goodies wanapewa wakizaa. So these are attempts to ensure that we implement UHC. And UHC, we are looking at issues around affordable services, accessible services of right quality, sawa sawa. And the key thing is it protects us from going bankrupt. Or tusiuze shamba, tusiuze wanyama, tusiuze watoto. Siku hizi hata nasikia tunauza body parts. Ili tufanye nini? Tupate huduma. So this is what UHC is coming to cushion us against. So some of the activities we've undertaken under this project is, one, we were looking at barriers to accessing healthcare services. And we were not just focusing on financial barriers, because yes, we appreciate that there are financial barriers. Mtu atakuwa mgonjwa lakini atasema sitaenda hospitali sababu sina pesa. UHC imekuja na tumeambiwa ni free. Si ndio? So, why else are people not going to the health facilities? Why else are people still going to the wanaitwaje, the TBAs? Traditional birth attendants. Sawa sawa. So we are looking at issues beyond financial. So some of the information that we gathered, the gaps that we identified was lack of correct and timely information about UHC. So the issues around sensitization, that hadn't been done, a lot of it. So people were not aware, people were hesitant. And across the 4 counties, I've heard about myths about UHC. Wengine wanasema ni Illuminati, wengine ni chama mpya, inaandikishwa, wengine ni kura, ati tushaanza kuhesabu kura ya 2022. I don't know if you've heard that.
Yes.
Iko. So yes, so information haikuwa ya kutosha ili watu waweze kufanya nini? Kuelewa na kuregister. The other thing was the confusion between NHIF and UHC card. Na hiyo tumezungumzia, si ndio? Do I need both? Do I need one? Who pays for this and such like things? The other thing was low enrollment with NHIF. I remember the first meeting we had, we were about 95 participants. And out of these 95, only 11 people had their cards, had registered with NHIF, and had their cards up to date. Only 11. Wengine wali-register, waka fall off the track 3 months, 6 months, 9 months, wengine hata up to 2 years. So these are some of the determinants as to why we get to the hospital or not. Another thing that came out, the most vulnerable groups are not involved. And yesterday at the stakeholders meeting, it also came out. There's a lady who's a cancer survivor who talked to us about what she's been going through, what she's been experiencing. And one of the challenges she highlighted is the persons who are living with diseases, be it cancer, be it diabetes, be it HIV. Most of the times we are not involved in this process, in this discussion. So we should be asking ourselves, ni sisi tunajitenga ama ni county inatutenga? Ama is it a two-way approach? And what can we do to assure that sauti ya kila mtu inasikizwa? Tuko pamoja? Negative religious beliefs. Kavonokia, ama inaitwa aje? Ni hiyo? Bado iko ama imeisha?
Well, in our region, it's not prominent.
It's not
But
prominent.
we know it's there. They don't go to the hospital.
They don't go to the hospital. So those are some of the challenges. Again, gender issues. Na hii wakati wa registration, tuliambiwa ati mimi sikuandikishwa ama sikusajilishwa kwa sababu mzee hakuwa na tuliambiwa kama mzee hayuko lazima tungoje mpaka harudi. I don't know how the process worked. Sisi unajua hatuna bahati, hatuna hii UHC. Again, you get scenarios where lazima tuombe ruhusa kufanya nini, haswa kwa kina wamama, lazima tuombe ruhusa kwa wazee ndio tuende hospitali. So those are some of the issues that contribute. Inadequate involvement of key stakeholders we've talked about. Infrastructural inadequacies, and that's at the facility levels. There are some services that we need at the hospital, at the health center, wherever it is, but they are not there. Either we don't have a lab, either the healthcare workers are few, either there is a reagent that is missing, and quite an array of issues. Another thing that strongly came out was persons living with disability. Kwa mfano, wenye walisema tunatoka katika mahospitali, vio vyetu inaweza tumika na watu wanaotumia wheelchair. And do we have people who use wheelchair in our community? They are there. So what do? Nimekuja na wheelchair yangu, then nasikia call of nature. What do? Yes, I can see. Ishamara. Naona ile macho. Tulikuwa katika facility ingine wakati tukaambiwa ati wanajipanga kabla wakuje. So you try to estimate, I am going to take 2 hours in the hospital, I am not going to take water, nihakikishe nimekula mapema and such like stuff. So these are some of the challenges that we identified, some of the barriers that we identified that hinder people accessing healthcare. And if we continue implementing UHC and we don't rectify some of this, are we going to be successful? No. So it's an approach that we can all take at the community level, at the facility level, and even at the county level. The other activity was on financial mechanisms. And we talked about that. We are looking at issues, how can we sustain? Because one challenge that is coming out is sustainability of UHC. What exactly can we do to ensure that we continue enjoying these free services? Or we ensure that we do not pay so much. Yesterday at the stakeholders meeting, there was a request that to expand UHC. So even as we start, sisi ni pilot. Sorry to say, I always like to call us guinea pigs. Tunajua guinea pigs ni nini? Hapo ni ile lab yenye tunafanya tests zote. So all the challenges that we are having, all the gaps that we are experiencing and everything, we need to bring them onto the table, because when we start implementation, because tunaona UHC itakuwa rolled out. So some of the lessons that are coming from Nyeri, this is what you are going to use in the other counties. Sawa sawa. So jana katika stakeholders forum, tuliambiwa we should look at expanding UHC so that isikue tu peke yake kwa public facilities, but we ensure that even private facilities ikue, lakini iwe tunafanya nini? Tunachangia. Tuseme we pay 50%, the government pays 50%. So this is some of the discussion we can still start having at the community level. Is it something that is viable? Is it something that we want to take up? Is it an approach that is workable? Are we together? So I think we talked about this. There is a poor uptake of NHIF, sawa sawa. And this was also confirmed yesterday by the manager, the branch manager, that we are not at where we expect to be. Very few of us are enrolled, very few of us are registered and are up to date. The other challenge that we identified with this is, even as the money comes in, the UHC money, this money is being sent to the health facilities. Yesterday it was confirmed that money has been sent to the health facilities. However, there's a challenge in that some of our facilities don't have boards. Amen? Boards. Hospital boards. That is from level 4, right? Level 4 we have hospital boards. Level 2 and 3 we have committees. The people we call HFMC. Tunawajua? Health Facility Management Committees. they are not there, or some, they have not been trained. So even as we send the money to the facilities, then there is that challenge. Do they have the capacity to run, to utilize this money properly? After that, we did sensitization on UHC, where we were just telling the community, this is what UHC is all about, this is what is expected of you, and this is what you need to do. Sawa sawa. So the first thing that was coming up is referral forms are inadequate. Tuko pamoja. I don't know if we've experienced this. It is true. So you go to the hospital where in your mind you tell yourself, si nitaenda tu nitibiwe na nitoke. Then you realize you have a referral case and you're expected to go photocopy the form or do something. So those are some of the gaps that were coming up in Mkurueine. Low infrastructural development, we talked about that, but key specific issue that came up was on ICT or IT. We need to have this infrastructure whereby the facilities are linked. By a touch of a button, wherever I am, I'm able to see my registration status. So that came out as a gap. We had a scenario where somebody said the registration was pending and they were not able to, they had to pay or they had to encounter delays and such like things. So these are some of the issues that were coming up. Inadequate staff, that was talked about. But again, we learned that a total of 233. Yes, 233 staff have been employed. So with time, we expect that this is going to ease. The other thing was the lack of proper identification. Right now, the cards, we've been told the cards are out. Sasa tufanye nini? Tutie bidii, tuende tufanye, tuchukue cards zetu. Again, we looked at the issue of the essential benefit package. And the essential benefit package, is those services that you are entitled to. For example, if you go to the dispensary, what are you supposed to get? 1, 2, 3, 4, 5 at the touch of a button. But it's not quite clear. This is not coming out. What UHC envisioned from the word go is a benefit package will be developed at the national level and this will be rolled out. However, there was a challenge. One, we have different scenarios. Sindio? Nyeri ilichaguliwa kwa sababu ya nini? NCDs. Isiolo? Maternal. Kisumu? Malaria. Wapi tena Machakos? Accidents. Right? So we see it's a very an array of issues. Sindio? Wengine wanadeal na maternal, wengine wanadeal na NCDs, wengine ni ma-accident. So even if we do a benefit package at the national level, it's not going to suit our needs, sindio? Kwa sababu, maybe inaweza egemea sana upande wa malaria, iache upande ya diabetes. So it is recommended that we customize for our own self. And the CHMT has come out strongly and has said, all services that are available at the facility. So ukienda kwa dispensary, zile huduma zote zenye ziko katika hiyo facility utafanya nini? Utapata under UHC. Sawa sawa. Then the other challenge was inadequate dissemination of information. There is frequently asked questions, sort of a flyer that has already been developed by this was done way before the launch of UHC. This package has not been disseminated to the community, so there is very little information about that. There are a lot of documents and a lot of plans that has been put in place, but the community is not aware of it. So that was another challenge that was experienced. So so far those are some of the activities that we've been able to do with the community. And out of those activities, these are some of the challenges that have been experienced. And the reason as to why we are highlighting some of these challenges is because we need to sort them out. We need to come up with safeguards to ensure that at the end of it, we are able to benefit from this whole process, because that's what UHC is all about, for all of us to benefits. So I won't go through all of them because we've talked about most of them. I'll only look at 2 issues. One is inadequate wash infrastructure. Tukisema wash tunamaanisha nini? Hii wash. Who wants to try? Any idea? Wash? Yes.
Water hygiene and sanitation.
Water, hygiene, and sanitation. So we realized there was a gap in this. Either we don't have adequate water at the facility. Sawa sawa. Either it's piped or we are relying on rainwater. So it's not adequate. Or, yes, we have sufficient water, but it's not well treated for us to consume it. Sawa sawa. Or we have water, but when we use our washrooms or our toilets, we are not able to get an opportunity to wash our hands so that they are clean. Tuko pamoja? The other thing is toilets. Our toilets are not marked. Sasa kama wewe ni mgeni, ujui kama hii ni gents ama hii ni ladies. Na unajua aswa wewe unasema mambo mengine, si lazima uji-expose sana. Si ndio? So it should be well labeled so that we are able to know that these are the ladies and these are the gents. Tusikue na hiyo confusion. Another gap that came out under WASH is disposal of waste. The waste that we accumulate at the facility. There are institutions that have to come all the way to Nyeri to dispose of their waste, especially the shafts. Zinaitwa shafts. Mimi si daktari hizo za kudungisha. Sawa sawa. So there was that request of having incinerators and such like things. Madaktari watatusaidia hapo. Then the other one that I'd talked about is the silence on PWDs, the persons living with disabilities. And when we are looking at disabilities, we are looking at an array of disabilities, be it physical, be it mental, and all of that. Are we able to go to the hospital? I can't talk, but I can do this. Na daktari ajue ni nini. Sawa sawa. Or I can't hear, and there is a way we can communicate. Then we also looked at sanitary facilities where our washrooms, if you have a wheelchair, then he's using the toilets, goodbye, until you leave the facility. So some of the recommendations is looking at that issue of interconnectivity, where we are able to link those health facilities. Feedback mechanism was a challenge, so we were recommending if we could revive our community dialogues. We used to have zilikuwa zinaitwaje? Dialogue days ama action days. Dialogue days. So if we could revive them to ensure that we are able to use them as feedback mechanism. We are able to discuss what is going on, and we are able to pick the gaps from the community level. Then there was the aspect of increased budgetary allocations for WASH. So we are here, and we've identified that these are some of the challenges. Si tumekubali ni ukweli? So are we able, as we do our budgets, as we do our plans at the facility levels, are these some of the issues that we'd want to bring up? Or ni sawa tu? Mimi niko sawa, naweza tumia hiyo, ni sawa. But we are a community, so we need to look after each other. Recruitment, deployment, and retention, that's the county is already working on, so I won't talk about that. Fast track policy review, there's a policy document that is being developed for the election of the board and staff. So this needs to be done as well, especially so that we can have these boards in place for those who do not have. For those who have, but they've not been trained, then we need to have that training in place. Then information dissemination, we just need to find a way of ensuring that whatever it is that we have at the county level, it goes to the sub-county and way, way, way down to the citizen. Daktari alisema vizuri tunafanya nini? Tunaweka kwa gazeti, lakini hatununui gazeti. Simu zetu ni mulika mwizi, haiwezi ona internet, Si ndio? So haya ni mambo tunafaa sisi kama citizens, what can we do? What constructive ways or what innovative ways can we use to ensure that tuko na hii ujumbe ina enea. Sawa sawa. And finally, we need to have a strategy for sensitization. Yes, we are working with 8 facilities in Mkureine. Is that sufficient? Is Kieni, is Othaya, is Madira? Gani tana? Izo? Tetu. Are they well versed with what is going on? Do they know what is happening? Sawa sawa. Then again, we realized there was this is information that we were not able to find completely, and we'd appreciate some help, though some came up yesterday. Like how much has been disbursed, if this money has gone to the facilities. Yes, we were told 780 million has come to the county so far. Right? Si tulisema madawa yako. Hiyo nimesikia katika every facility that we have enough medicine. It's because out of our 780, 60%, of which that is 399 million, ishaenda kwa madawa. So that one we are sorted. Some of the questions we were asking is, the money that is going to facility, what is it based on? Is it workload? It wasn't so clear. Then again, it's not clear how much the government has put in for UHC. I don't know if there is a separate budget for that, or it's just the health budget that is going into UHC. So these are some of the questions that, or some of the answers or clarifications that we would appreciate. Thank you very much. I don't know if there's a question or a clarification. And please, let's make use of, I can see rich brains.
So one gap I saw is the boards or the committees. So people don't know who they are, how they got there. I've heard Dr. Mureu say they are constituting new ones.
Yes.
So I want to know what is the process. Do you involve the public? Who gets in there? And because does the public even know them? And that is a big gap.
It has to come from the Director of Medical Services. So that report is forwarded to the DMS, and the DMS at the national level. So the DMS has the final decision. We have really tried to request the DMS to devolve that function. Because you can imagine if this is coming from the 47 communities. But I think also because of fear of abuse, you can imagine the court is asking. People, there's usually disability at times is defined, but there's a criteria to it, and that's why we task it to a committee. The committee gives that proposal to the DMS. The DMS also has a committee at the national level. So that is usually the procedure. Because I've also had guys who come to my office and attend, and this I should not be quoted, the media is in the house. Whereby someone, probably they are 60 years, but they want to go to 65. They don't want to retire. So if at all you have any, maybe you're involved in an accident, you see whether there's a way you can be classified as disability. Because that then gives you an opportunity to serve 65 years. So it can easily be abused. Maybe the other thing I want to answer is about the question that was asked about IT. Under UHC funding, it's important that we recognize that we have, the money is divided, as you had 60% goes to cancer. The other money is in several components. We have public health services, covering what issues of sanitation, issues of ensuring that we have some tools. We also have community. Here has a big robust community health system. I'm sure some of these people are here. We can be able to support some of the activity, like the screening they do. Then we also have a component that we call health system strengthening. So it's basically to look at, and that's where some of the money we are using even in employing staff. So within that, there's going to be a budget for procurement of basically IT support. So that is where then that facility is going to be assisted. But in terms of saying that there is no network, I think that is something that is beyond health. The only thing that we can do is one this data, because in terms of uploading the data into the DDS system, that is done at the sub-county level. So once they have their data, then you can submit it to the next level. Let them know that is key. But all they have, we don't have system. Because I think that is beyond us in terms of ensuring that it's better. I know even when we did the emergency registration, there was that challenge, whereby you would have the areas where there was no network, you actually have to load it. And one of the things that we didn't tell these guys is probably because there was a lot of things that were discussed about it. So I think it's just a question of the time we've had discussions with them in terms of doing everything. But in terms of computer deployment, the IT support as part of health system strengthening.
There's going to be health system strengthening. So some of these gaps, it's upon us to do what? To identify them, highlight them, so that once we get these resources and the process starts, then we can see how all of this is brought together. Tuko pamoja?
Now we go to monitoring the health services that are being provided. Yes, and that is, I'll be doing the presentation on the citizen involvement implementation of health development projects in Nyeri County. That is the report we did, which looks at the period of 2015 to June 2017. So just a brief background on the Nyeri County Budget Coalition, which basically spearheaded this whole entire process of monitoring the projects that were being implemented in the county. And since after devolution, there hadn't been any guidance to the public on how to mobilize themselves. After devolution, the constitution ilikuwa imesema lazima kuwe na public participation. Most of the citizens were basically, we were confused on what we should do. How should we organize ourselves? Because most of us used to develop memorandums, and the county assembly and the county executive will get like 10 memorandums. None of them was speaking to each other. They were all confused. Sindio? That was the challenge that we experienced basically here in Nyeri County, where we have been working for the longest time possible. So that's why we decided as a group of civil society organizations that work in Nyeri County, we decided to come up with a Nyeri County Budget Coalition, so that we can bring civil society organizations together, so that as much as we are developing a memorandum, we are developing a memorandum that has everyone's input into it, so that we don't have like 20 memorandums going to the county assembly and giving them a very big challenge to analyze them and basically just give their inputs. So that's why, that's when now we came up with the Nyeri County Budget Coalition, which consists of CSOs and citizens who live in Nyeri County. And the coalition was established in 2006 as a loose network that promotes transparency and accountability in county government budgets through enhanced public participation. And specifically, the coalition aims to promote timely dissemination of county planning and budget documents. I know we are always in Kirira's office requesting for these documents and just disseminating them now to the various citizens that we engage in at the sub-county levels, and then advocating for budgeting that is aligned to community priorities and mobilizes for public participation, and offering oversight on county budget implementation. So the coalition consists of non-governmental organizations, faith-based organizations, community-based organizations, and even professionals who work in Nyeri County, including Nyeri County citizens. And what is the approach that the coalition uses in carrying out the objectives that I have just outlined? Number one, we usually have CSO planning level meetings, whereby we hold consultation and budget prioritization meetings to review the various county plans that exist. That is the County Integrated Development Plan, the Annual Development Plan, and then from the analysis, we usually draw agendas for engagement with the county executive and the county assembly, and then we appoint representatives for key sectors. Since we all know that civil society organizations are basically, they run from the health sector to the education sector, so we usually have to come down as a coalition and agree on who is going to lead the education sector, who is going to lead the health sector, and who is going to lead the agriculture sector, so that as much as we are sitting down as a coalition to come up with memorandums, we are touching on every sector within the county. And then now, when you look at the executive level, where the executive proposes a spending plan, we usually engage the CSOs in the network whereby we commission an analysis and critique of the budget circular. That is the first document we usually analyze. And then the county integrated development plan, the annual development plan, the county budget review and outlook paper, and the commission on revenue allocation formula. So we usually interrogate these documents so that as much as we are coming up with memorandums, they are aligned to the already existing county plans, and we are not coming up with totally different proposals that the county may not input into the final budget documents. So we identify opportunities for the coalition members to input, and basically most of the opportunities that we get are the public forums that the county holds, and we also hold our own forums depending on some of the issues that we want to pass to the county. And then we share, during these forums we share our views and the critiques that we have on the draft documents. And then we develop and submit memorandums, both at the county executive and the county assembly level. And then now when it comes to engaging the county assembly, we usually analyze the county fiscal strategy paper and the final approved budget, whereby we conduct we assess if any of the CSO's recommendations were taken into consideration. So when we are engaging the county executive, we presented proposals. And now when it comes to the county assembly, since the county assembly also looks at what the executive has put in place, and they also they approve with recommendations or without recommendations. So we also engage them to ensure that despite our proposals having gone to the county executive, we also try and push our proposals at the county assembly level. So we approach it at the two levels to ensure that if the county executive hadn't picked on some of our proposals, the county assembly will definitely look at our proposals and try to see whether they can incorporate them into the final budget documents. And then we usually hold roundtable meetings with CSOs and members of the county, of the committees of the county assembly. And then citizens' suggestions are repackaged into budget proposals. And then finally, we hold post-budget forums. The post-budget forums are usually important because now we analyze whether the proposals that we submitted to the county government have been incorporated into the final budget document. This is usually important so that we are able to even engage the county assembly and the county executive on whether on why some of our proposals did not make it to the final budget document, so that now it informs our coming year budget analysis, engagement processes, so that we are not just shooting proposals left, right, and center. We are basically making informed proposals that will make it into the final budget documents. And then during the implementation stage, the Nyeri County Budget Coalition basically monitors and tracks whether funds used to implement development projects are approved in the budget. So this is the section where the report that we are launching today was utilized, and what we did basically, we capacity trained CSOs and county officials on monitoring budget implementation, and then we went on to review the budget monitoring tools. The budget monitoring tools were reviewed. We already had budget monitoring tools, but we had to align them to the county, to the county structures in Nyeri County, and then disseminated the revised and pre-tested budget monitoring tools. And then we went on to access the official budget to identify all health development projects, their budgets and the incurred amounts, and then we mapped out their geographical locations. So this guided us on basically the facilities that we are going to look at. The budget documents were the ones that informed which facilities we will target at the county level. And then we facilitated the trained monitors to go and collect data using the budget monitoring tool, and lastly, the activity that we are doing now on launching the report. So Heraf is a non-governmental organization that is a part of the Nyeri County Budget Coalition. And with the support from the Center for International Private Enterprise, we were able to basically conduct all the activities that I have mentioned on monitoring the projects that have been implemented here at the various facilities. What was the target population? These were community members, community healthcare workers, religious leaders, healthcare workers, community health committee members, health facility management committee members, the county government official, the county health management team, from these 14 facilities. That was Nyeri County Referral Hospital, Karatina, Mukurweini, Gitero, Tunguma, Karigweine, Ruguru, Tungari, Njokine, Ishamara, Karafa, Ruruguti, Wamagana, and Mudangari. So those were the facilities. Mudangira. Oh, sorry, Mudangira. So what were some of the challenges that we experienced? Number one was recall bias. Remember we told you that this study was carried out in 2018, and the projects we were monitoring were from 2015 to 2017. So basically that's a long period for people to remember what had gone on during that time. So this is important because now, remember, we are now, it was kind of like we have already shot ourselves on the foot, so now we are trying to remember, did I really do that or did I really not do that? So yes, the community members may not clearly remember the information required in the study. And then number two, the members of the CHMT and the facility in charges do not have project financial records. When we wanted to commission the project, the monitoring exercises, we thought that the CHMT, that is the County Health Management Team, and the facilities have information on, have financial records. But this was not the case. Now that is when we were informed that this information sits at the procurement office, and we had to go and get it from that office. So we didn't collect data from one specific area. We had to go to other several offices to get our information. So what was the sample size? We used convenience sampling method, whereby when somebody, we were targeting community members who were at the facility accessing the health services. It was convenience because that we had to ensure that whoever was being questioned had to have used the services, and they have information on what basically happens within the facility. So a total of 510 people participated across the 14 health facility. And the data collection method used was basically interviewing, and basically we got 326 female were interviewed, and a total of 181 respondents were male. And this is basically because more women than men responded to the survey because of women's health-seeking behavior. And then looking at the age, we find that the age ranged from 35 to 55 years were at 48.2%, followed by 18 to 34 years, which was at 31.2%. This is attributed to the fact that the youth frequently seek education and sources of income outside their rural dwellings. So we found that most of the people that we interviewed were basically not the youth. They were people who have already tried everything in life, and they have now come down, settled down at their respective areas. And then data analysis, the data from the questionnaire was analyzed using SPSS. So the first area we looked at was on public project identification. We basically know that there are 4 areas that a project goes through. That is identification, planning, budgeting, and implementation. So we wanted to understand, during project identification, what usually goes on within the community. And according to the data, levels of community participation in identification of the public project varied from one facility to the other. And we found that the highest ranking was Mudangira Dispensary at 98.7%, followed by Karigweine Dispensary at 70%. The lowest ranking was Tungari Dispensary and Wamagana Health Center, where respondents stated there was no community participation in identification of the public projects. So from the data we collected, basically the total number of people who said that there was public participation was at 25.5%. That was 25.5%. And as I had mentioned, Mudangira had the highest, who are saying yes. And one of the reasons that was given on why Mudangira had mentioned that they had public participation was because it's still a new facility. So people are still very excited on having a new facility, and whenever anything is happening, they are very ready to go and see what is going on at that facility. So that's why there was very high public participation in identification of the project. And then you can see Nyeri no one mentioned that there was public participation, and that is because it's basically an old facility, and we all know if something is old, no one really wants to engage in whatever is going on with it. Cindy? Yes. So that was basically the interpretation of this data. And then now when it comes to project implementation, on the level of community participation in the implementation of the public project, 23.5% of the respondents mentioned that there was public participation in implementation, and we find that 50 did not know whether there was community engagement, and 25.6% said that there was no public participation. So now when we move on to the data, it basically has the same structure as when the project was being identified. You can see Mudangira still has 90.0% people saying that there was public participation, because it's a new health facility. So people are very excited about it, and they want to know what is going on, and they want to engage in the entire process of everything that is going on. But now for facilities like Nyeri, which are basically old facilities, you find that during implementation, people, as in the year in, year out, we are used to what is going on in that facility. So you just bring what you have, and we can go on. So you can see that basically the challenge is also that the citizens are basically not interested in what the government is doing. That's one of the things we identified. When we looked at the costs of the project, since from the data you have seen that in identification the community stated that there was low participation, and now so we wanted to see whether when it comes to the cost, what happened in the cost, and we sought to establish whether the projects were implemented within the budgeted amounts. So from the budgeted amounts, whether what was budgeted for is what was actually used, and from this you can see that the budgeted amount and the actual expenditure. So seven of the facilities that I have mentioned had actually used less amounts. That is 7 of those health facilities. And then 4 of the public projects were implemented as per the budgeted amounts. That is 4. So meaning 7 plus 4, that is 11. 11 of the projects, let's just say 11 of the projects had been implemented within the budgeted amounts.
Aspect of integrity has been put in practice even without oversight. Even without oversight.
Yeah. Cindy, because despite us saying that there was no public participation, most of the times when you go to the community, what do they say? That in public participation forums, at governor analeta watu wake. Cindy, most of the times we say that the county government is bringing its own people to public participation forums. They are not engaging us. But in the real sense, isn't it the public who are not really interested in what the county government is doing? Huh?
Not once have I heard they said, you can't call me when I'm busy doing my work the whole day to come and listen to you. And then sometimes it's because of previous experiences they had. I remember going to another place, then when I asked them, why aren't you coming for this CIDP? When we started now as CIDP, they told me, unajua hiyo ingine tulikuwa tumeandika. You did exactly, you called us for the previous CIDP, you did nothing, go back and consult the same document, Because whether you call us or not, we are not coming. Then I remember one of them asking me, they told me, do you know how many pipelines are here? And no, pipes are in my ground. There is this for this irrigation from previous year, this other from previous year, this one from previous year. 3 of them, and none of them has running water. So go back and look at the previous CIDP. So basically sometimes we have to look at the dynamics that are current now, which might be very different from those previous ones, because we cannot depend on the hang-ups of yesterday. Are they coming now? That's what we need to ask. Are they coming now, or was it before? I don't know.
You were shaking your head like this.
This is recent.
I have attended as many public participation forums as possible by this county. And I can tell you one thing. The public is not aware what that document is. So even if you tell them it's a CFSP, it's an ADP, it's a CIDP, it's a CBROP, they don't know. Number 2, and I'll say this, and they are here. They did the CFSP, it's the latest one, yeah? County Fiscal Strategy paper. Now what the county did, and correct me if I'm wrong, and they are here, that is not a CFSP. That is not what we expect from a CFSP. And so you had people being told to stay in sub-counties, and you give your priority projects. And I challenge someone, hiyo document ikitoka, show me one word and one project itakuwa kwa hiyo document. So the reason why Waziri anasikia people saying we did the same last time, it's because the executive or the county government side is treating every document the same way. Wanakuja wanaambia the people, so give us your priority projects, even when the document does not want that. So a county fiscal strategy paper was different. Case in point, the executive did its own yenye nasema. There was no draft. So when there is no draft, what are we discussing? And so you find the public is not aware, 1, of that draft, 2, what the county is doing. So what you need to do as a county government, and I've insisted, is first hold a forum and tell the people what is this document we are going to discuss. Then give that document at least 2 weeks in advance to the public so that they're able to go through it, not that day the forum is happening. And so you'll always have public participation as a challenge in Nyeri because of the same. So my view is that the public, utapata, most likely ni mimi tu nitaelewa huko Mokoroini somewhere there what that document means. But the rest, wataambiwa tu, and this time you involve the MCAs, it's a good thing, it's a good gesture, and I see the speaker is here. But then the MCAs take over those. When you divide them into wards, the MCA goes and takes over there. And so you see an MCA now is the one bulldozing the projects that are a priority for the people. And so some MCAs are very, he knows, some MCAs are very vocal and they'll push that. So there's a lot of improvement that is needed, and that is my view, because, okay, the government is trying, sisemi everything is bad, but a few things. Teach the people what that document is, give them the document in advance, and you'll have a good, lively forum, and they'll be coming when they feel that's it. But now, when they go, they feel, umempea ki document, ADP is quite large, and they are supposed to go through it very fast and give their views. Na pale wanakimbizwa wanaambiwa, you know, MCAs kwanza usema we have sessions in the afternoon, so harakisheni mtuambie kile kimemleta, we do it. As for transport, just cascade these public participations as low as possible. Makueni is doing it. I went to Laikipia just to see when they said they are doing at sub-location level. Nikachukua pesa yangu nikaenda just to see they are doing it at sub-location level. So we are doing it at sub-county. We do it in my place, Madera. We do it hapo panaitwa Kaiafa. Somebody from Rogoro to come all the way And Waziri came to the first CIDP ADP forum, and they were saying that. I was there. Come from Rogoro. Actually, they didn't come. So you come from Rogoro, I come here, then I go back, and hakuna transport. So if you cascade it closer to the people, they won't ask you for transport.
I want to say one thing, and I want to support what the last speaker has said. I wish public participation can be continuous. Why am I saying this? Nelson has said an MCA comes and hijacks the process. My colleague has said when the MCA calls with the order themselves there, they are able to engage in a better way and bring out the issues. So I've already said this. I want to understand what is public participation. What we are doing here, we are doing public participation. And I know what Katrina said is that we have many brains here. Let's exchange ideas and learn how to do it. I want to tell you Nelson something. That when we talk about a draft, CFSP draft, I get lost. I have seen many counties saying they have a CFSP draft because that is a starting process of preparing the budget. So what I'm expecting is the public to give me their views. And again, I have another problem with the planning in this country. We have an annual development plan. I have seen it in so many forums before. We have an annual development plan, which we presented to the county assembly, and it was approved. So in that public participation of the CFSP, we are only pulling out what is capable to be done within a financial year with the resources available. Because we want to introduce anything new. So what the national concern is, and you are my colleague concern is, how does ADP reach the people before the CFSP discussions are held? And, okay, we have talked about the generation we are in and the life in the ordinary environment. That the website is not an area where every person can access. But because our ADP is always in the website. So when we come in those 2 hours, my thinking has always been, or how we visualize the CFSP process, is that we have the information from the ADP. We are only going to record it and saying this project is more critical, project A is more critical than project 2 because of ABCD. Because we will tell you with the resources available, we receive about 2 billion for development every year. And we have taken a different approach. And I want to say we have taken a different approach whereby we are saying we are going to dedicate a specific amount of money per ward in the next financial year. So that, out of that 20 million, 30 million, 50 million, okay, we'll talk about 30 million for a start. We will be able to get to know which projects are priority in a particular ward. That is where you are looking at it. But the draft is the ADP. You're talking about an ADP for 2019-2020, which the members of the public can access. And I can also tell you from a program that we are running through the World Bank, supported by the World Bank, we are going to have civic education, and we'll be talking about these documents more and more to the public when we go down there. We are training about 50 persons per every sub-county. Those will be actually educating the community continuously on what the government is doing, especially on planning and financial matters. Makueni, there's a Hadi Kenya. Most of these success stories, there is a force behind it, there is support behind it. So let's also consider that Makueni is a big county, okay, it's a small county with a lot of donor support. And I've also always said this, I'm looking forward by 2023, or this census we are doing to this year, how much poverty have you reduced in Makueni? 86% of the people in Makueni live below poverty line. I want to see a single digit from 86, at least 85 or 86. I will say hallelujah, work has been done. But so many other things, there are sort of support coming from the donors in Makueni. Like Laikipia again, we have compared Nyeri to Laikipia. Nyeri is 2,200 square kilometers, about 3,300 when you include the forests. How much is Laikipia, the size of Laikipia? 10,000 square kilometers, size of Central Province. So when they go to a sub-county, to a sub-location actually, they are actually not even covering a ward in this county. You may consider the distance. I come from Laikipia. Yeah? From Gobit to Suguta Malma. That's what the boundary is. From Narumoro to Suguta Malma. So the unit, our unit which is we're using as a sub-county, might be a sub-location in that county called Laikipia. But as we move forward, we will improve, but let's have faith in our MCAs. That's a thing I would like to request all of us. Reason being, these people are always, the MCA is always with the community. And they have very many forums. Let by the time, by 15th of February, I cannot hold a forum before February. We cannot purport to be having a CFSP discussion or a budget forum. Reason being, we are not even aware how much this is going to get from national government. We normally get the information, the firm confirmation of how much this is going to get on 15th of February. That's what the PFM Act dictates. So any other time before that, I cannot report to be having forums to discuss the budget. But you can have forums, the MCs, pick their issues, put them in the ADP, have that ADP disseminated to the public. So next financial year, we'll be talking a document we are all much aware of.
When Speaker, you guys do the supplementary budgets. We want to see them uploaded. And you know, it's like these are the changes. I can see the Assembly did the CFSP at Wambogo Farm, and they showed movement of money and justifications. So that is a nice thing they are doing, because even the public that was there, they could now tell how money is moving, and that is important. So when you move money in the supplementary, atuseme ni vibaya, and it's already there under the PFM Act. But just inform the public why you are moving money from development side of health, umeyeka kwa recurrent, so that we know what you are doing. Otherwise, you just create what Waziri was saying, aingiangi social media, because you create that avenue for people to guess what you're doing with money. And when people are guessing, they guess in Kenya and Nyeri the wrong thing. They'll just say, imeibiwa, Kirera akona gari mpya sasa, and you know, those are the things. So you create avenue, yet you could have just explained, we have moved money here and there. Wacha watu wapige kelele one day, but you've justified. But when you leave it like that and someone picks it up, they'll just share and show movement na hatujui kule imeenda hii pesa.
We are thinking very hard even to move more resources from development and buy food. Because we are saying, as a count, and my Honorable Speaker is here, we can't allow a person to die. For whom are you construct the roads for? For whom are you construct the hospitals for? So we are thinking about along those lines, and we are still observing how the situation will be. We do a supplementary because of an emerging issue. The last budget we did was because of UHC. UHC was not in the original budget. And we are told the money is no CLF account. Actually, we are talking with Dr. Kamau here, Newton and Mureru here, asking ourselves, what do? We are being told move the money to the facilities. In fact, and I thank the Assembly for that, this is a local time, just a budget, a supplementary budget within a 1 week period. Because money is in the account, we can't provide medicine. That's an emerging issue. Now imagine, Nelson, within 1 week, you call public participation, you tell them you have money for UHC. Yeah? And this money is being waited for. Can you imagine within a week? And the president is asking us, you people have given you the money. Why are you not giving medicine to our people? So it's an emerging issue that always makes us do a supplementary. And the question of moving from development to recurrent. You remember the time we had the CBAs about the doctors on strike, nurses on strike. Again, do we call the public? And they are aware the nurses on strike. To tell them that now I want to move money to pay for salaries. Sometimes I want to say for the interest of every person, we are put into a corner, and as a responsible government, you provide solutions. But in the notes, they are also indicating in the notes why we move like 40 million. We had a big staff in the health and in all the departments without insurance cover. I think that's the issue you are raising. And again, within that time, when we were doing the supplementary on UHC, there were so many other issues which were pending, and we had to sort them out that time. Development, we always take 30%. That's the law. We must always provide resources. Within our budget, 30% must go to development. And we have always stuck to that condition, and we are going to follow that one.
Yeah. Okay, so there were 2 projects that were ongoing and had not exhausted the amounts budgeted for. 2 more projects that had already used up the amounts budgeted for but were not complete. And then, as I had mentioned, Karatina Sub-County Hospital, we didn't have the report on the expended amount for the generator. So that's what I hadn't touched on. And then we also went out to ask whether people knew the amounts that were used for these projects, the amount that was going on into these projects. And basically only 3.6 of the respondents mentioned that they knew the amounts, but the rest didn't know. That is 18 people knew the amounts. So you can see that. And then we also wanted to find out whether people knew about the project and the contractor, and basically procurement information about these projects. And we found that only 8.5% of the respondents stated there were advertisements for contractors and suppliers. And then 2.4 of the respondents knew the contractor and how he or she was identified. And over 19 of the respondents agreed that the contractor got manual laborers around the project area. So you can see that only 8.5% knew, had information on the contractor and how he was identified, and basically what entailed in identifying the contractor. We also wanted to understand how the community felt about the projects that had been implemented in those health facilities. And despite the data showing that the public had little levels of public participation in implementation of projects, quite a huge number, that is 67.3% of the respondents were satisfied with the projects, as shown in this table. So 22.8% were very satisfied, and 44.5% were satisfied. So that comes to 67.3%. So you can see, despite the public not saying that they weren't engaged, they didn't have any information of what was going on, they were very satisfied with the projects that were implemented in the counties. So in conclusion, there exists sufficient policies and legal structures supporting public participation. Sindio, kuna the Constitution, there is the Public Finance Management Act, there is the other one is the Procurement Act, there is the county Public Participation Regulations 2016. So all these policies basically provide a legal structure on how public participation should be conducted. And looking at the 2015-2016, 2016-2017 annual development plans in Nyeri County, all of the projects that were monitored were actually outlined in that document. They were outlined in the annual development plans. And so we were looking at the third phase of the budget cycle, which is the monitoring the implementation of the budget policies as planned by the executive and approved by the county assembly. So this is the crucial phase whereby we find that citizens have to explore how accountable their government is in utilizing their resources as they committed in the approved budgets. And quite a huge number, that is 67.3% of the respondents, were satisfied with these projects, the projects that were implemented within those facilities. And most of these projects were complete and in use and had very little defects. In the report, there's an area of the report card where we outline whether the projects had defects, and very few of them had defects. Basically, actually, just 2 had defects. The others were quite good, and they were in place. And the study revealed that 4 of the projects were implemented as per the budgeted amounts, while 7 of them utilized less amounts. Hence, there are major attempts by the county government officers to follow the law and implement the projects as approved. So what are the recommendations for this report? Number 1 of the recommendations is that capacity build rights holders and duty bearers on provisions in the County Public Participation Guidelines. We all know that the Nyeri County Public Participation Act was developed in 2015, right? Sindio? But the county was, the Public Participation Act was developed right after, before the County Public Participation Guidelines, which basically clearly stipulate what needs to be undertaken regarding public participation. So we felt it is very important that we looked at just trying to ensure that we train both the government officials and the community members on what is in the public participation guidelines, so that they are able to understand what is expected of them. Because most of the challenges we identified was that most of the community members don't know what is expected of them. They don't know that they are supposed to go and monitor this project. They don't know that they are supposed to, when a public participation forum is called for, they are supposed to go to it. So we need to train community members and the government officials to ensure that they are both on the same page, So that as much as the county is calling for public participation forums, the community knows the importance for them to participate, and they're all on the same page. Number 2 is that the county to provide other information channels to its citizens for them to effectively play their oversight role in public project implementation. So, like what the CEC had mentioned, Dr. Rachel had mentioned that they provide that information in the website, right? Sindio? But how many people can access the website? So one of the recommendations is for the county government to basically just look for other avenues in providing this information. And one of the things we outlined was notice boards, facility health notice boards, or even the creation of an ICT resource center. A resource center where somebody can just walk in and get all the information that they need in one place. So that's that's the number 2 recommendation of this report. The third recommendation is to revise and update the Nyeri County Public Participation Act 2015 to align it to the County Public Participation Regulations 2016. The Public Participation Regulations 2016 have clearly outlined what needs to be done when it comes to public participation. But the Nyeri County Public Participation Act doesn't clearly stipulate what needs to be done. So the County Public Participation Act needs to be updated so that it can also have the same theme as the county public participation regulations. And lastly is to increase citizen awareness on the importance of monitoring public project implementation. So one of the challenges faced in ensuring public participation in implementation and monitoring of projects is the lack of empowered citizens who are able to play the oversight role in monitoring implementation of public projects. So we find that at the community level, the community is not basically empowered to the level that they are able to follow up what is going on regarding the projects that are at the county, that are being implemented at the county level. So they need to be empowered for them to be able to play the oversight role. So create awareness through massive public awareness creation on public participation campaigns through the radio, television, public gatherings, capacity build its residents on public participation through trainings, and hold public forums at ward levels to reach out to more citizens. I would like to call upon Joseph from Kenya, who will lead the plenary session, which is the next session on our program. Now you can ask your questions.
I think one of the, I don't know how we need to have an education program in our community so that people can take responsibility over public things to feel their individual things. And basically, some of what we do comes from our taxpayers, what we pay as taxpayers. Today, if I had a big lorry and decided to pour garbage on the middle of the road, you know, nobody would stop me as a citizen, whoever you call as Wajiko, to tell me I'm doing a wrong thing. Or I need to look at them as Kali and ask them, isn't it? We don't have that where somebody feels pain, that Wajiko that we are talking about, feels pain, and sees that the effects of not acting will harm them later. And until we do that, then we have a big problem. You can talk about community participation, talk about anything else, but so long as it's like we have been made to feel that, so, and culturally it's true, that if you're stealing from the government, you are not a real thief. A real thief is the one who has stolen from my house or something. And we have to have a whole mindset for the citizens as well. Because so long as they don't, what will come is they'll start attacking because they want either political systems. And that's why you find people even wanting to attack whoever is there because either they want to come up to that position. It's not because they are genuinely feeling that they're lost.
So I think begin first with us before you tell another person what to do next, yes?
Since the county is making it through that is civic education department, which they have already launched, they have a desk on the same, let them do the best daktari, because the desk is there, it has succeeded. And we have already given a recommendation that let Honorable Kagushia and all the MCAs be incorporated in the desk so that we can be able to reach to the person down there. Whatever means they will use And we assure you people, the money is there. Just use any means to get down to the Wajiko. And when you get some people to just educate Wajiko, Wajiko will hear. Let's see the response after. And then we'll judge her when she has already hand. Sinu query. But at least the county is making something as far as the civic education department is concerned. I think, was it about 6 months? Down there. We gave a recommendation which is actually really materializing. And we are very happy.
Again, from Heraf, I learned about something called essential drug list. And so I would like to know, is there a relationship between that and the drugs the Auditor General said expired? Because I'm trying to wonder if that list has drugs, like let's say a lot of malaria drugs, and this place hakuna a lot of malaria, and then drugs zinaenda. So is that list responding to what Nyeri patient, if we are leading in NCDs, then I would hope the drugs that are essential to us are responding to that. That is two. Then the medical equipment, the MES. So we get them, but they are inadequate staff to handle that equipment. I was in a focus group yesterday at Kaiafa, where the lady running that facility said, like, laboratory ya huko I think imefungwa because the lady is on maternity leave or something. So now it's closed, the lab. And so we are having these challenges. We'll have UHC, it's a good concept, we'll have it. But now those teething problems. So if lab has only one person, now ameenda maternity leave, it is shut. So that is another one. I would like to also encourage Waziri. I heard you say something to the effect that UHC, hakuna one point for UHC, like we should spread the gospel. But I would like to encourage, let there be one, I can call it like a center of sorts, where we can get frequently asked questions and you respond to them so that we get information there. More like an info pack. So right now, if I want an info pack on UHC, I have to look for someone, I had to look for someone who's at the subcommittee at UHC at the national level. Because at this level in Nyeri, which is a pilot, I can't find the data pack that is about UHC so that I learn more about it. So the county should have more, one-stop shop sort of facility. Finally, to the economists in the house, procurement is still a challenge. And so, have you sorted that out? Procurement, every time I read your documents, a project, now health carries a lot of projects. You will see delays because of BQs, you wanasema BQ and procurement, if miss failure, if miss fine. But procurement is controlled by the county at that level. So if you know, and we have posed this, if we know, Mr. Kirera alikuwa anasema, we already know what we are going to do through the ADP in 2019-2020, the next financial year. So why don't you start procurement early enough? So, you know, some of those things. So economists watatuambia if they are sorting that out, so that we don't see that in all their reports.
Remember these 20 shillings at the health facility used to be the one that would employ who? The community laboratory person. They could buy the reagents, and they could do a lot of work with that 20 shillings. Immediately when the money was removed, we no longer could employ the lab staff, because remember they were not employed by the government because of the wage bill, and they could not be. Now it ended up being more expensive. The same person we wanted to help, it became more expensive. Because now they have to move to a big hospital where they use about 100 shillings for transport, and then go and pay the same amount which they were told not to pay at that rural health facility. So you can actually see that has been an issue. Over time, because of the many CBAs, our wage bill moved from 1.5 billion to 2.1 billion. Basically, you haven't added more staff. What you have done is you have added what? You are paying them more salaries. So at the end of the day, you already have an issue with the auditors because you are already using over, your wage bill is over, under recurrent is over 80% already, and they are saying this cannot happen. These are dynamics that are coming, and UAC is actually being able to help us to address some of these issues. We have a focal point at the MOH. We have Dr. Marion, who is dealing with issues of, who is dealing with issues of UHC. And as I get, we need to have, as we said, we need to have a database where we can actually continually be able to update you on what we actually are doing. Issues of expired drugs, actually, I learned from the place. I was wondering, we were busy discussing in a meeting, which are these expired drugs, you know? Sometimes you don't even know where the expired drugs, because actually they were not even there in the first place to have expired. But remember, there were some drugs that expired over 10 years ago, some of them, because when they used to push to us. But now, since we are actually requesting them, they actually, they hardly ever expire, because they give us, this KEMSA, that person, I don't know, he was working from KEMSA, they give us drugs which have a longer expiry date. And even if their drugs are almost going to expire on their hands, they even call the mission and call anyone else to ask, do you need these drugs? Because they don't want them to expire on our hands. So basically, remember, the disposal of drugs takes a long time. So sometimes you can have backlogs of expired drugs that were there even over 20 years, and people are trying to see how to dispose them because it's expensive. But in terms of drugs expiring on our hands, I guess whoever wrote the report can come and basically, you respond to that. You mentioned about delays in BQs. This is true, they are delayed. And it's, the more projects we do, the more the delays. And the government actually is sorting it out. Now these days you find like our QS had to go to hibernate and be able to address them. We are also looking through the same system that we employ more people to be able to address these issues. So the issue is also being addressed. We note that there is some delay. It's being addressed so that you have enough manpower to actually deal with these BQs. Remember, we have one side where we are being told the wage bill is high, and yet on the other side, we really need this staffing to be done. And I'm sure some of these delays, previously the delays were more because it was mainly a new government trying to sort it out, to sort itself out. To establish one, it took even a long time because we lost the other governor. This time we might not have the same excuse as we had before, but we have to ensure that all this has actually been done. Unless you talked about the mess equipment, most of it is working, and is, unless it might be a different, there's a difference between mess equipment and the normal equipment that is in dispensaries. We don't have the mess equipment in any dispensary. Actually, they are either in Ukraine or PGH. We don't have all the other equipment. Some of it we bought. Before, even previously, the communities used to buy the microscopes and also help us. And we've been able to get, sometimes we get money, the grant, you know. When they removed the 20, it meant now we had to get funding from a grant. And you know, when you're getting from a grant and it's from a partner, if they delay giving us the money, it also affects the rural health facilities performance. So it's not like before when the committees would actually be able to get the money and then able to use it. Any free service that comes and you have to depend on the money coming from outside, any small delay affects us. But basically now, as you mentioned with UAC, most of these resources have been budgeted for, and eventually when you hear there is no drugs, when people tell you there are no drugs, remember there is no, even if you go to now the hospital, you can never have all drugs, ever in life. Those who are in the mission hospitals will tell you, there are certain what we call essential, what caters for 99% of the people. There's only that one drug, and you can't ask KEMSA to give you immediately, because the procurement process takes also longer. Even sometimes we have drugs here we need urgently. We try to borrow. We can borrow from Consolata Hospital. They'll tell us they don't keep. Even Auspani will not keep. You have to ask for meds. Some of them you have to actually be able to sort out. And some of them are difficult ones, like the ICU ones, especially if you have to feed a person through blood. We are not talking now of 1,000. We are talking of 1 million per person. So you can actually see, if you have such a budget and it eats on to that budget, what happens eventually, you end up having shortages. With UAC, we are lucky. We just pray to God that we proceed on in the same way, because then we are able to get monies quite faster. Before, we didn't want to incur debts. When we incur debts, they're also on our side. They tell us, you made this budget, now you have incurred many debts. It means you are actually consuming more than what you are required to use. And remember, I keep asking, sometimes if you have no money for food, you don't have a choice, you have to ask for a debt. You'll kill us, but at the end of the day, you can't tell the patients you can't feed them because money has run out of for food. But actually with this, especially the new government, and I just want to thank God for His Excellency because he's concerned about health. Do you know every week he walks in the hospitals? Has anybody realized that? He walks around to see and talks to patients so that we're able to address the customer care. We have even hired a person to deal with customer care in our hospitals because we realize they are stressed, but sometimes we still need to encourage them to be even nice when people are stressed because they really work hard and give their very best. But sometimes, you know, they get burnout. They need somebody else to actually support them.
Your first question you asked about UHC package. And there is no defined UHC package. I think that's one thing that we all need to agree. It was a major mistake because what now the counties are left to do is to offer anything and everything that they have. So if you walk into PGH Nyeri, anything that we are stocking, even if you fall and you are admitted into ICU, you will be admitted. All the ICU feeds, you will get them for free. And in the unfortunate situation that you pass on, you transition, we will keep your body in the mortuary for 7 days for free. So meaning that anything that is done within the county is actually public hospitals within the county, they are free. Any service that is available. So you'll only incur cost where maybe a service is not available, like sometimes you'll be sent for diagnostic, maybe CT scan, maybe specialized MRI to Madari. That's not available at PGH. But anything else is free. About medicine, I think that one has been clarified. So what happened, what informs the kind of medicine that we draw from KEMSA is number one, based on consumption and the need. So mostly the NCD drugs are what is available. I don't think that there is anybody now who is going on diabetes or hypertension at any of the public facilities, including now the dispensaries, and they are not getting. Then you ask about what are we doing about NCDs. You've noted Nyeri is a very unique county, whereby I think, we normally say we've always held our PGH, our county referral hospital, as a jewel. And majority of you, if you come from Nyeri, you know, we have that notion that kama hujaenda general hospital, ugonjwa wako haijafika, haujapona, true or not. So we have that notion. So what happened is that when we got UHC, instead of people appreciating that we have lower facilities down there, that they can start with, we all flocked into PGH. So you've seen the kind of congestion that we have. So there are a lot of things that we are planning because we have doctors, they are quite overwhelmed at PGH now, but now we are saying we need to trace these people back. So we will have, how do you call it? We'll have outreach clinics so that also the objective of UHC number one is to ensure that the population do not incur catastrophic financial expenditure. And by you coming to PGH, because sometimes you will come almost 5 times in a week before you really get to see the consultant because of the queues. So what are we saying? If you come from Rogoro, if you come from Bereview, now we'll have clinics coming there. We have equipped laboratory. We have a consultant coming there, so that you have one-stop shop and your issues are sorted within a day. I think that is how we need to engage and actually see how do we help, because otherwise, if the doctors keep on remaining at the PGH here, waiting for patients here, patients will continue suffering. And you'll have instances where somebody will come and die in the queue while waiting, because most of the time these diabetic patients will come early in the morning when they've not fed on anything. So those are some of the innovations that we are trying to think, where now we can have a rotation, because the beauty is, with these clinics, most of the time when you attend the first one, the next one you are given in three months. So if we can afford to come to Bereview, to come to Rogoro, to come to Narumoro, to come to other places every month, it means that even if the consultant is only to see 12, because the first time when you're seeing, you find that the consultant will not see many because he want to dig and actually ensure that you got the right prescription because atakuona tena after 3 months. So before you get that, then this other time there is a clinical officer who is there to handle the management. So we'll also have maybe a medical officer who is able to see about 30 or 40. So you see, if this is done, and people appreciate that UHC is working within here. I think I've seen, and the reason why you go to PGH, you see, we used to see about 560 patients on average every day. Now we are seeing about between 830 and 1,000 per day. So you go to that place, kuna mtu alikuja asubuhi na atatoka hapo kesho asubuhi. Kwa sababu ametumwa lab, amerudi. Queue bado ni kubwa. Anayetumwa, by the time apate prescription ya kwenda kwa dawa ni 10. So 10, hawezi pata matatizo kwao, anaanza kwa bench. I don't think then we are encouraging health. We are actually discouraging it. And since we have the supplies, what we need to do is also now to see how we get where people are. I think that's one of the things. You asked a very a question that I've seen actually it's already in social media on expired drugs. Before devolution, we used to have a push system, ya madawa. Nobody used to order. Ministry of Health in Asukuma. So you could get Nyeri receiving malaria drugs, they're receiving all sorts of drugs. So the audit has picked the value of expired drugs that actually we have. And these are products dating pre-devolution. Because for drugs, for you to dispose of drugs, you almost need a license from NEMA. Madawa, hatuwezi enda tuweke kwa mto, hatuwezi choma, you don't know. So you actually need a license for you to dispose. And you see, as a county, when you're holding that much, in fact, it's a lot. And you go and actually look at even the expiry dates. They are dating those years, some of as old as 2009. So it's true, those are there. And it is not just in Nyeri, it's actually cutting across all the counties. Even we have communication from Council of Governors, where now they are telling us on the best way of disposing them. So maybe soon they expired, so that then we can also account, because we also need to be accountable to Nyerians. Tulipatiwa hizi milioni zote zikawekwa KEMSA, we can't afford to go there and then we are drawing. Unajua hata si pesa tunatoa, mbona tuitishe tuweke madawa ambayo we are not using. So that is there. It's dating pre-devolution. Of course, I'll not say that we cannot have or we are not having expiries, because hata kwako si chui ina expire at times, hata uga inapata whatever. But the quantities are not. In fact, if you quantify what has expired actually since devolution started up to today, it will not be more than 3 million. So, and that's a fact. Those are the data available, but you see, everybody will pick on just the color that is negative. So I thought it's good to clarify that. Then laboratories, I think we are trying to operationalize laboratories, and not just operationalize. See maneno ya microscope sasa, so that you can do a wider range with what we've talked about devolving or having those outreach clinics. We want to tukikuja kama ni Karafa Health Center, we will not be coming with any equipment. So ni daktari tu unakuja naye, because of course we not afford a doctor everywhere. So unakuja na daktari and the team. Equipment that will be used will remain there, so that even the clinical officer who is there, they are also mentored and they can request some of these tests. You get. So I think so far we've done about 10 dispensaries. So if I can be allowed to say it, they are called hematology analyzers, the biochemistry analyzers. So these that will do higher, a bit more complex analysis of blood to get to know where you are having. So this is the same test that when you go to outspan, you'll pay about 1,500 or even about 3,000 depending on the range. So these are now available within these facilities. So I think it's a matter of time. So we are also recruiting. We don't have enough lab technicians to handle this. So there was a first attempt to recruit. I think we are also doing that, because UHC we are out to recruit about 91 staff. Out of 91, we already received about 56. So the other gap has to be filled in the next maybe 3 weeks or so.
I've visited almost every department in PGH. That is our referral hospital. And I found the priest is now working, operating. It's doing well, better than before. The mortuary is very well kept and good. But there are two areas that I'm never comfortable with. One area is the casualty. To me, that is not a casualty. The other thing, the other priest is Ward 6, and I quote Ward 6, let me name it, Ward 6B. Because there is Ward 6, let me say Ward 6A, because I don't know how they name it. You'll enter A before you go to B. Yeah. B, to me, it's a deathbed. It's a deathbed. I don't know. That ward, I have a history with that ward, Ward 6B. That is the other side. It is near the toilets. It was used for those people who are suffering from HIV, and they were kept there because they were near the toilets. That when now they start diarrheaing, they would just push them to the toilet. Then they were pressed with there was that time. But nowadays, it's like it has gone back to that. I went there. The priest, yes, the priest is better, but they still have that whoever is in that ward, because most of them are HIV positive guys, and those who are PP, I think HIV positive. And it is like there's still stigma in that room, in that ward. That's why you get people with meningitis, very sick guys, nobody care very much about them. You see relatives coming, requesting to take gloves and taking care of them. I visit that room as a passion. And I've been saying day in, day out about Ward 6B, that whenever your patient is there, you'll be sure when he gets out of that place. I have clients who are frost in that ward. Casualty. Casualty is all about the wash person. It's like washman in the hospital. And I've been saying this about casualty in PGH, whereby you are welcomed with a language that is not that friendly. And I'm saying this because I've talked to the administrator about it severally, and it is like there is nothing. Now that we have the chief officer here, please do something about casualty and Ward 6B.
I think CHVs are doing great work, because in Nyeri alone, what happened is that actually they are the ones who are able to tell us. But you are now, there's a lot of issues, including mental cases. You know, a mental case, before it's detected and brought to hospital, they are the people who actually helps us identify. And you see, the network of CHVs, in fact, like in Nyeri here, Nyeri Town Health Center, that is just next here, we've started a program whereby now we are trying to retrace, rehabilitate, give them drugs, and connect them back to their families. And if somebody deserves to be, and I think because also it's good to say this, because I know Heraf, you also have interest in mental health. If somebody requires to be admitted, we actually take them to the hospital. So that is purely an initiative that has been done by CHVs through our office, and it's working well. True or not, actually, because you're in this Majengo. Then the other item is that we want to work on detection before you talk about curative. So in this year's CHV, in this UHC budget, we have about 30 million allocated to buy kits. You know, we have the glucometer and the BP machine to be given to our 2,510 CHVs across the county, so that at home they're able to come. Kama uko na shida, you'll be the first to detect. Kuambia kama sukari yako iko juu and what you need to do, kama iko chini, what you need to do, because they are also trained. They are given basic training, and this training will continue. So they become actually the village doctors. In fact, that's how I prefer looking at them, because in the village we have somebody who is just next there, and they don't cover a big area. Every location we have 10. So you can imagine, in every village we have a CHV. Then the other question that actually came in, I'm surprised that it's coming from somebody who works in a hospital. Really surprised, because why I'm saying surprised is because it's a very clear form that actually need to be submitted. Because anything happens, you can buy unga ikuwe ni ile chungu, true or not? So if there is a way of complaint, you know, if now this complaint comes to this meeting, are we going to sort it out? There is a form that actually is in all the public pharmacies that gives details to raise complaint, and this complaint actually is documented. And if that complaint happened, and then maybe a sample is taken to the lab, or even they are common, actually KEMSA normally recall drugs. That's why any drug that is coming from KEMSA has a batch number, so they'll come and recall the entire batch. And they did it, must be about in November, there's a drug actually they recalled after the complaints. So I think what you need to do is just to have a proper documentation, so report to the pharmacist. And if you feel that this is not hard, our offices, we are normally here. Anybody who has ever come to my office ainanga appointment, just come and actually report it, we will take an action. So it's just here in PC's building, the block A. So if you feel that you may report to the hospital in Japatikana, bring that complaint. Because at the end of the day, I think what else will we be doing if our people here, this has a cost has been incurred and you continue consuming drugs that are not assisting you. So I think that's important. You go to women ward, the throughput is normally very fast. Kwa sababu mwanamke akisikia anaumwa na bavu na pengine ni kulala vibaya ako hospitalini. So for men, I think we just need to have a proper education for all of us, and I wish we are more of us just to get this, because that's something that is ailing. If you get, you go to that ward, on average, a patient takes about 14 days. You know, if a patient, on average, of course, kuna ule wa siku saba, kuna ule wa month plus, because we go to the hospitals when actually you are on resuscitation, so you are trying to bring you back because ulienda. So I think that's why the condition may look so bad, but it's because we also don't take care of our own health. And I think that is also a role that actually CHV need to come in, because we need to encourage our men. Number one, now we have screening, even especially for things like prostate cancer.
I think people are just getting sick at home and nobody was going to the hospital. Because the influx just came. It's the only word you find every time there are two people. And both of them are very sick. Is it true? They can't even turn, somebody has to turn them, they have to be washed. And therefore, if you look at it, even the health workers look overwhelmed. Two. And sometimes you find even a coach. You know, a coach made into, what do you call it? Into a bed. Until we have reached a stage whereby it gets full, we give instruction, no more admitting patients in PGH on your medical mail. You come, we'll take you to wherever there is space. We take them to Karatina, and we take them to Mukureni. Of course, people don't feel very nice. When they are told like that, some of them, if they think they'll throw a few tantrums to the health worker, if she's stressed, she also throws back. She also throws, because there is that instruction that you cannot, even sharing 2 beds is wrong. Now somebody wants even a third one, and it's on a 2.5 feet bed. Are you understanding? It's important for us to understand that with UHC, because it's free, those who used to go to mission, walitoloka. Those who used to go to private, they have come back. There are those ones who could never even get available health services, they also reduced. And over time, PGH, the wards have reduced. Over years, other hospitals, the wards have increased. Actually, in PGH, the wards have reduced. Because in previous governments, when they could be told, look for a place to rehabilitate for ICU, they would take a whole ward and turn it into now an ICU. So basically, you have lost the bed capacity that was there within the hospital. Then they are told, they will have a Lino unit. Now instead of, and they want only to rehabilitate, they don't want to build a new, they pick another ward and make it into a what? A Lino unit. HDU used to be also a ward. Then they were told they want another ward. They also wanachukua ingine. So basically, the hospital's capacity has reduced to its. Learning best practice, because we visited immediately when we were appointed, we decided to visit Machakos. Machakos were wiser than us. When they would be told they need a new building, what would they do? They would make a structure very fast. Was, aloof, and say this is the building. Rehabilitate this one. For us, we actually picked a ward. And remember also, the demography within our country has changed. We have an older community, and therefore we will see very many old people. I remember we once had a camp, and the camp was in Nyeri, in Karatina, because of one of our late governors' memorial. When I looked around, I've never seen so many old people, most of them were over 65. There was even the press like, oh, many people are sick, they're not being attended. Most of them had their medicine in their pocket. Most of the medicine was in their pocket. Because they had Aga Khan was coming, Guru Nanak was coming, many consultants were coming. So some of them were just coming to confirm or have something different that could be done to them. It made me realize that we have an aging community, and this aging community will be getting sick with NCDs, and most of these NCDs are not easy to control, especially when they come late. You find some of the people you find with oxygen, their heart is failing because they have been having they have been having high blood pressure, and then again they're also diabetic. And that's why we actually are looking into other ways. How do we decongest some of these hospitals by transferring elsewhere? Even over time, even the assembly has actually come to accept that we really need to start thinking of how do we increase more space for patients. But you see, Rome was not made in one day. You all know our equitable share, how much we get. And I want to report, even the governor keeps telling us, if he has to give us all the money we need in health, what would he do in this county? He would have to stop everything else to be able to meet our needs. And therefore, we appreciate what we get, but we are trying to improve. As we get more drugs now, by the way, it's even better. If you go to other wards, people used to take long because they would wait. If it's on a Friday, you have to wait until the cashier comes either on Monday. People have to go back home looking for money to be discharged. Now we are even discharging them faster because cost is no longer a barrier. You talked about casualty, and casualty is an issue that if people are rude, we need to address it. And actually also recommending that we don't want to kill all the good people because of one person, isn't it? So if we have that person, let us know, and we know how to deal with that particular person, rather than saying the whole of the casualty is rude. But you go there on a Monday. How many people do you get on a Monday? Over 1,000. What happened? We increased the drugs. Did you increase the infrastructure? There is still the 7 clinical rooms. And those 7 clinical rooms, we have even a place where we share 2 people. And you can see issues of confidentiality is coming. We didn't increase our infrastructure. Actually, over 1,000 people, and with that infrastructure, it's something we are building up. And it's nice now to realize what is the true picture of health services in Nyeri, so that you can be able to improve our infrastructure, because the central government is supporting us, the county government is also supporting us. So soon we'll have no excuse. We need to monitor and see, are we improving? The worst thing is we need to ask, going backwards never, but are we improving? Are we making baby steps every day to improve quality of services?
We're doing some survey in PGH, and we realized that patients were very satisfied with some of the services that they were getting, except only some few departments that they had challenges on, which I know probably is in the report. Just some few departments. So otherwise, we appreciate you, the work that you're doing. Now, in this junction, I see there is somewhere written, probably still will give you another opportunity still to come and maybe address us in the implementation of public health development project and the patient satisfaction of health provision.
Fortunately, as a speaker, when I came to this county, one of the things I found in the budget was a 14 million car. And when I drove in the car which I was allocated the first day, I felt it was comfortable and it was looking good. In any case, I was not used to riding in big cars like that. I used to have a very old X-Trail KBJ 900. And when I rode in that one, I felt it was comfortable, it was good. So when I found the 14 million in the budget, I asked, so what is this for? I was told it's for the new car for the speaker who comes in. And I said, surely we can use this money elsewhere. So we had to transfer the money to do a supplementary to have the money allocated to another area. We had some allocation in the budget for the speaker's house. But when I closely scrutinized the circular which had come from the COB, I realized that circular was talking actually about governors and deputy governors. For some reason, they had omitted the speaker. And so I died with that. I asked the clerk, let us reallocate the money for the speaker's house, match to other activities in the county. And so when you see the 50 million in the budget, it is not for the speaker's house. It is for renovation of the assembly and upgrading of the assembly, which of course again we also did a supplementary and put into maraming of roads in the county. So what I'm trying to say is that we have the attitude of trying to have as much money as possible, especially anything that touches into the speaker's office, we have as much as possible said we want to keep it very, very lean. That is why when you come to my office, you'll find even the old carpet that we found there. We said we don't have to change. Some of the MCAs see on the TV, the speakers, when we have wrangles in other assemblies, they see the speakers, they have big fridges, big nice carpet, big TVs. But our assembly office is quite humble for those who have come there. And we have not really wanted to invest in that. I'm saying this because we're in the mood of discussing the issues of budgeting and much more for health. I have seen severally people trying to compare the budgets from this side and this other side. But of course, sometimes we've not end up achieving the real intended purpose, especially when we compare, for example, the salaries that we are paying the MCAs and the health budget. Sometimes it doesn't add up because the budget for paying salaries for the MCAs is usually very separate from the budget for the health sector. There's no mix of budgets. The budget for assembly and the budget for what we are doing in the health, in the roads and all that are very, very separate. Nevertheless, I have been following the discussions that we have had here, and I can tell Heraf is doing a good job. And I want to congratulate Heraf because they are actually now partners with us as an assembly, because our work is oversight. And we are supposed to be helping you, the wananchi, to ensure that you realize value for your money. The money that you're paying as taxes, the county assembly is supposed to ensure that we put the executive to task to ensure that that money is actually of value to you. And from time to time, we receive a lot of input from you. I have mentioned Lucy here because there's a day I called her, because there's another Lucy, there's another lady with her name who kept on calling me about Mukurweini Hospital. I've had another teacher calling me again about the same hospital. And we have highlighted with the relevant bodies about what was happening there. Nevertheless, I think the issue of public participation. First, if you look at the report that Herald is launching today, I have seen you quoting the issue of Public Participation Act of Nyeri County, and also that is 2015, and also what we have in 2016 in the country. And in my opinion, we are not lacking in terms of structures, in terms of legislation which supports public participation. If you look at Article 10 of the Constitution, it is very, very clear that public participation is one of the national values. And so we are not lacking in terms of support when it comes to the issue of legislation. On that front, we are good. What we probably need to do is to put our minds much more into it and to have a goodwill of public participation. We have ensured that at least every time we are doing a public participation. Nevertheless, I'm still convinced that up to now, we are still not probably doing it to the level best. Neither are we having it done properly by the executive, nor are we doing it to the level that it should be done even at the county assembly. And one of the things that we intend to do as we move forward, and I really have to sit together with our house leadership, and probably once we do it and we do it very, very correctly, as one gentleman talked about, I think the one was explaining about how it has been done in the past and how it is also being done in other areas like Mukurweini. One of the things I think we need to do is to actually take this public participation much more to the local area, other than even the headquarters. I mean, we have, when we are starting the process, we have more public participation on the ground. So if it is a budget making process, we need to go to the local radios and advertise and say, we are now in the process of preparing this particular aspect of the budget. Whether it is ADP, whether it is a fiscal strategy paper, whether it is actually the budget estimates themselves, we need to do that. And once we do that and we call you to attend those meetings and educate you also and probably have also platform in the media, with that we are able to sensitize the public. And then we'll not have the issue of that the public doesn't know exactly what documents we've been talking about, isn't it? And the other thing, of course, would be also to upload all our documents in the websites, in our websites. When we have a document that we need to go and take it through public participation. I saw, Nelson, you circulated quite a lot what we had put in our website last time in the strategy paper. Circulated all over to the people, and I also ensured 2 or 3 days before we did that public participation. I actually went to Inoro TV, and one of the things I really emphasized was about that public participation we were having, so that more people could be interested and they could know what we are doing. And really, this is important because then it brings the voice of the masses. On the issue of procurement process, I believe the executive order that was given by the President as of last year, 2018, and it was supposed to take effect from 1st July 2018. This kind of takes into consideration a lot of these comments, Christine. Yeah? The issues of public participation in as far as procurement is concerned, where all the people who are pre-qualified, they are uploaded in the system. Any person who is associated with any of those companies, their names are also put in there. How much it is going to cost is also put on the website now, or in the system. Now, of course, there are a lot of people on the ground who do not get to see, or who may not be able to access these kind of systems. But we have those who can be able to access, and just by the fact that you're putting all that information to the public, it means that then people are going to be more careful about what they are doing. And we have the issue of putting the signboards. I remember one time in my village, in the last regime, there is a signboard that was put that we are doing 7 kilometers and of this road. But what was done? Patch Marami, which did not even go for more than half a kilometer. And people were up in arms. And that road had to be redone. It was repeated. More Maram had to be brought. Because people actually demonstrated in my village at that point. I remember getting a lot of calls also from Nairobi. We can see this is happening. Can you also help us? And of course, when we raised our voice, there was a repeat of that job. Now, that can only happen when people have the information. But if you don't know where it starts and where it ends, how then will you put your voice? So that is what you must do. And there's something else that we need also to do, especially when it comes to the issue of health, involvement of the community health workers. As of, I think it's about 2 weeks ago or 3 weeks ago, I remember there's a report that was launched in Kigali in the HIKE conference called the Community Health Workers Guidelines on the Service Delivery. This was launched by WHO. This is part of what I was proper. Yeah, yeah. I'm saying this is part of what I got from my roommate. Now, you see, she attended that particular forum in Kigali where they were launching that report, and so she's one of the persons who is very interested in this. So the issue of participation and involvement of the community health workers in the whole process is very important, because they are the people who have most of this information, and they are the ones who actually knows where the shoe pains. Yeah, and so that involvement is very, very important in the process, and they also understand. There are many things that other common people will not understand, but community health workers will understand. Why? They're also exposed. They get training. They get these kind of interactions. And so for that reason, they have a little bit more information, and yet they are in the villages. They're in the local area. So that is one of the things. In the assembly, we have had, I think by now we have actually had about 3 motions that have been brought by MCAs in support of the community health workers. We have Honorable Dumia from Kamakwa, who brought one. We have had Honorable Derito, Mugonda Ward, now he's the chairman of Health Committee. He has also brought one. I'm not remembering the other one, but you have also had another one which was brought to do with the issue of support of the community health workers. And one of the things we're saying is that they also need to be included. When we are making our budgets, Daktari, these are some of the people we really need to consider in those budgets so that we can support the work they're doing for us. Again, one of the issues that is also coming up is the issue of funding for level 2 and level 3 hospitals, which are most close to the mwananchi. Probably we need to do more in that regard so that we not over-concentrate on the level 5 hospital. Once we have also emphasized on the issue of funding those hospitals, they get their share, I'm sure more people will be treated at the local level. And we have, of course, the issue of investing more in the primary health, preventive, early diagnosis. That really is something that should help us much more in the health sector, especially in our county, where we have issues of, is it communicable or non-communicable diseases? Some of us who are not in the health, sometimes we confuse which is which. Yeah, so, of course, we need to have, and they should be among my very last points, is we need to have very, very deliberate policy formulation which supports service delivery improvement in our level 4 hospitals. Many times there has been a surprise that you go to Mukureni Hospital, you go to Odaya Hospital, and it is quarter full. You come to the PGH and it is overflowing. People are sharing beds. Why is it so? Why can't we make Mukureni Hospital to such a level that we don't have to have a lot of people coming to the PGH? It is possible that can be done. And maybe one of the things that we can do is by making them centers of certain things. You make Mukureni to be a center for eyes and ENT, isn't it? Yeah, so all the eyes and ENTs, we have a specialist there, and that is where any person who want to see a specialist, they go. Then you make Karatina, for example, to be one for renal issues, isn't it? Then we kind of decongest the PGH, and we only have those very, very referral cases there. Now, we are looking forward to having Odaya Hospital now, level 6 opening, hopefully soon. We hope this will improve the landscape. But if we don't improve these level 4s and level 5 to a very high standard, we are likely then to transfer PGH to Odaya, isn't it? And of course, you know, it will be a competing hospital because now even people from Kiambu and Laikipia and every other place will be coming there. I want to emphasize on the issue of the role of the member of county assembly. And I want to give this as my last comment. The members of county assembly, this time round, some people have been asking, how comes we are not having as many fights as we have had before between the MCAs and the executive, isn't it? You know, the public is very interesting. When there is a lot of fights, they ask, why are these people fighting so much? Wait, we are going to show them the best. Come 2022. That's what people would say. And then, when again, they are not fighting, what do you say? Tumenyamaza sana. Hapa iko kitu. Hapa iko kitu. Kuna mtu anatuenjoy hapa. Iko kitu. But basically, I want to explain to you very briefly what is happening. The members of the county assembly, one of the things they are always fighting for, even where you hear they are fighting with the executive, is to have a bit of control in terms of what is done in my ward, what is done in my ward and in my area. And in many counties, that remains a very, very volatile area, very, very sensitive area, very active conflict active area. In our county, what has happened is that the executive, and I want to thank the governor, the executive have sat down with the assembly and agreed that the county assembly will have an active role in identifying their projects or the projects that are going to be done in their wards. And for that reason, there is much more participation of the MCAs in terms of identifying what projects, where, and how much funding to be given to those projects. Now, why is this important? It is important because when you people have a problem, you don't rush to Dr. Kamau here, do you? No. You don't. When you have a problem, you don't rush to the governor's office, do you? You don't. Where do you rush to? The MCA. It is the MCA who comes to the barrios. It is him who comes to your Maombolezi. It is very difficult to see MPs going to Maombolezi. In fact, if you see MPs in Maombolezi, you wonder why they are not busy. Wait until you don't see an MCA. You wonder where they are. It is them who interact with you on a day-to-day basis. When they are coming to those Maombolezis, it is them who experience the hardships and the problems which are on the way, the roads and all that. So, a chief officer, for example, like my brother here, yeah, he's a technocrat. He's much more involved with the work in the health ministry. But an MCA who is in the village, they are the ones who sometimes they get to know when there are no medicine, when Panadol is depleted in the dispensary. They get to know before the, even there sometimes even before the head of that hospital, because you miss the Panadol there the first time. The second patient misses, the third patient will most likely communicate to the MCA. Tunatua tuende tukanunue dawa. And most likely we are being told to buy medicine from the from a certain chemist. So by that time, MCA anaju, so they get to know so much. And so by allowing MCAs to participate more actively in the process of budget making, what are we doing? We are basically saying, we are bringing sauti ya mwananchi karibu na budget, isn't it? The budget is now becoming more inclusive. And I dare say, if we have more powerful MCAs in Kenya than in Nyeri, I don't know. It is in Nyeri where we have most powerful MCAs now. Because today an MCA in Nyeri County can stand in your village and say, hii barabara nitafanya hii. And it will be done. Yeah. It will be done. When they point at your dispensary and say, this dispensary we are going to renovate, I can assure you, just like the way sun comes in the morning and goes down in the, that hospital will be done. That is a good thing, because now it means that you can lobby projects through your, and that enhances public participation. So that becomes public participation, which is now kind of inbuilt. We don't even have to call a meeting, so that people can give their, you see. Now, definitely we'll do that. We are not saying that it will not be done. But what you are saying is, even by the time we are going to that, you will find that your voice has already come to the budget. So that is a good thing. And this is the first budget probably that we are going to have with the full participation of the MCAs in terms of their voice and in terms of their preference, in terms of the projects. So it means then that you can pursue our members of county assembly to ensure that certain projects, which of course must be the ADP, must also be the CIDP, are actually done. And they are doing that. And that is also helping us now to start prioritizing. So you find in coming days, we are going to have less of projects that are not adding so much value. You know, there are those projects that people do and they don't have much value. There's an MCA, for example, who was complaining that I heard there was a chief officer launching something to do with the beekeeping in my village. I have not seen those beehives, or even if I have seen the beehives, I have not understood how even that honey is going to be marketed or sold, isn't it? Yeah. But the MCA was saying, if I was the one being asked, we could not have invested 6 million in a beehive project. Instead, we could have done it more in the dairy cattle. To let Siemens, za AI, isn't it? Zile quality za kupatia wananchi, isn't it? So you find that with the bringing of the MCAs into the budget making process, we are helping our wananchi. And so I can say that is why, that's one of the main reasons why you hear there's a bit of quiet in the county, because the MCA's voice is a little bit more louder than it has been before. I remember when the MCAs came with their proposals, there's someone who whispered to my ears and told me, Speaker, now you need to be very careful. Hii proposal nimeona MCAs wakileta hii, hii ndio ilifanya ule governor mwingine akuwe impeached. You remember there was an impeachment here, which actually went through here, isn't it? Akaniambia hivyo, nikamwambia tulia, relax, relax, because what we have understood is that the governor is not, trying to be a strong man, a big man who now says, because what we get as a problem is where one person takes all the resources and anakanyangia wapi? Sasa anaanza kudish kulingana na vile nyinyi mnakuja mmepiga magoti. Now when we remove that and we distribute the resources to all the MCAs, kila MCA anajua kwake lazima akiamka anaona projects za milioni 30, 50 million, whatever number of millions, and when you see those projects happening in your villages, then of course you know that things are moving. Maybe then what you need to do is to lobby help to be part of what is put at the front. I know we have the UHC, which has helped us a lot as a county, but UHC, as you can see, a lot of money is going to KEMSA for drugs. But there's a lot of issues to do with the staffing, there's a lot of issues to do with the infrastructure. Although I also think we also need to really be very, very strategic. Sometimes I look at a place like Mukurweni, because I come from there. And sometimes I also ask myself, have we also invested very correctly over the times, over the years? Because I look, for example, at the maternity wards that we're having in Mukurweni now, and they are quite, I don't know whether you people have found that. There are so many that some, nobody has ever delivered there. Yeah? It is true. You go to Mukurweni Central, for example. We have Langadi, which is a level 3, and which can actually even be promoted almost to a level 4. But there we even have incubators, we have very modern beds. Maybe Daktari, we need to make use of those things. Yeah? But nobody delivers there. I think only one baby has ever been delivered there. For the last like 5 years, we have had those equipment. Yeah? Maybe we need to look at that. Okay, sometimes you ask them and they say it is because of the services that they are likely to have there. So we need to check, do we then need to change the service providers, or what do we need to do? Unfortunately, having not had a baby delivered at Dangade Hospital, we now are doing a maternity at Ishamara. Isn't it? Isn't it? And if you look at them, they are 3 kilometers apart.
Away from the
isn't it?
sub-county.
Then look at Ishamara and Mukurweni and with the Karatina. Isn't it? So you look at that and you see that they are very... Okay, then go to Karafa. I know Karafa, I know we don't have, but Karafa is also not very far from Mweru. We have Mweru, where we also have a maternity wing, which is not maybe properly functional. And of course, we have, I don't know whether Jokine, we have a maternity.
It's not in use. There is the structure.
It is there, but not in use. But we also have another one we are doing in Tambaya, which is incomplete.
And I don't encourage still Mododini, there was that proposal.
You can say, I know Mododini, there was. Yeah. So, you know, I know, I can tell you, public participation can be good and it can also be bad if leadership is also not very strong in guiding. Because what does a woman in an area want? Them, you know, they don't, sometimes they have no that expanse in terms of what is also happening in the next neighboring village. So sometimes they just want a maternity. And so they push for that when you go to the public participation. But as leaders also, we also need to look at where do we have what. Because you may have public participation of people wanting what their neighborhood, the village, has. So if you now, of course, so that's why also we say a leader ordinarily should not lead people where they want to go. A leader also need to lead people to where they ought to go, so that they can see the bigger picture. So we need to look at those things and assess. But what I can tell you from what I know, especially in Mukurweni, for example, you cannot say you are starting, maybe except one area called Kangorwe. You cannot say that you are going to start a dispensary anywhere in that area now. What you just need to do now is to do improve on services. Bring labs, and when you are bringing labs, you don't even need to come up with a structure. More often than not, you'll find there's even an empty structure there. So we just need to enhance that capacity. So it is possible we can be able to get there. I'm happy about this meeting on human rights. Is an advocacy forum, so it is enlightening na imetusaidia pia sisi sana, and I'm very happy that you also found it right to have a county assembly participate actively in this meeting. I want to give apologies for my chairman of Health Committee, Honorable Joseph Derito. He was meant to be here, but then he had also spent yesterday the whole day in UHC, and because he was in the UHC, so today he has now been catching up with his committee meetings. There is a report that we are trying to do to help Daktari here. You know, Daktari, we say in the assembly, we are not punitive. So when you hear we are doing a report trying to check on how the health system is working, it is not because tunataka kukosoa. It's not because we want to pull you down. Yeah, because we decided we are not going to work maliciously as an assembly. And even those who sometimes who prop up those kinds of malice, we tell them we only want quality things. So we are trying to also check, maybe we can see how we can also work with Heraf to check what really do we need to do in our health sector. And this has come because of quite a number of complaints, much more on the issues of just service, much more on the issues of, I think, customer service. Customer service, Daktari, customer service. That is where we probably need to. And I'm happy you're already thinking of employing.
Yeah, she's there already.
Customer service.
Yes.
Yeah, and then we also train all the other staffers who serve people in those hospitals, so that they can be able to engage with people in the right way. Because someone who is going to the hospital, they're already sick. They need to be treated with some kindness, isn't it? Yeah, they need to be talked to nicely. They need to be given a bit of morale. They need to be told, you will be okay, isn't it? Yeah, but not being, you know. So that is one of the things that, and it's a culture. It's not something that has come with this county government. It is something which has been there over time, something that can be improved, can be done. I like the way sometimes when you go to Outspan, the way they wanashughulika about the customer service. I think they are very good sometimes with the customer service. But sometimes it's not because they have even better services than what is in PGH. But sometimes those guys will treat you until you feel like you are healed even before you take medicine. Yeah, so we can do it, and so we are trying to see as an assembly, how can we also work together with the executive to help to know what is where. And I'm happy because over the time now, our chief officer, the health department has continuously now opened their mind and their door, sometimes even to criticism, and also to corrections, to improvements, and that really helps us to move forward, because none of us is complete. Hata kwetu nyumbani ya tupo 100%. We keep improving. So when we are told here we need to improve, what do? We listen and we improve. So we launch the report. Yeah. So now, this is the launch of the report. Citizen information, involvement, implementation of the budget. So this report is now officially launched.
The Director of the Finance and Economic Planning Office to come and just highlight on how they have been providing sector financial and economic guidance on project implementation.
I have some few points here. One, how the Department of Economic Planning is intending or has been doing to involve the public in the budget implementation. One is the public participation at the sub-county level. The other one is the one that the Honorable Speaker has stressed, the engagement with the people's representative, that is the MCA, in the budget making process. And on this budget that we are going to make of 1920, we have fully involved them, and we will continue engaging with them as we make the process. We also, in the process of launching a popular version of our CIDP, where we can take it to the Mwananchi, a small version of our CIDP, if I say small version, but it contains the key information to know, like like a pamphlet where you can read most information other than the key booklet, which Mwananchi cannot read. The other one is the financing the established civic education department in the current financial, the year you're coming, so that it can be doing civic education down to the Mwananchi on the government agenda of the day, huko mashinani. The other one is the, as our CEO has stated, is the training of the 50th person per sub-county on civic education and public participation to become a TOT in that area, so that if they ask what is, like Nelson asked, they don't know what is a CLSP, they don't know what is a CIDP, the C block, somebody can explain to them down there. We are financing that department through the Kenya Devolution Support Program in the next financial year. Then we'll be designing, printing and dissemination of training materials as to be people's friendly. Like I have said on the version of the CIDP, the popular version of the CIDP, so that if that person read that document, it's not about numbers. Like me, I'm very good in numbers, another person is very good in English, so that it can come to one level. Even if we will not do it in Kikuyu or Swahili, but a friendlier version that somebody can be able to read. Then we also intend to procure notice board to those sub-counties, so that you can know when you give a roadmap, you can, even if there's somebody in sub-county, will know the roadmap of that budget. We stop presuming that everybody knows the budget circular, where it starts, where it ends, then we put them in those sub-counties notice board. If somebody will come, will be interested, if you be interested to read, will read from the sub-county levels. Then, in the same way, we'll be putting the notice board, we want to put a feedback mechanism, either be it a complaint box or a suggestion box, that will be specifically manned or addressed by our department. Previously, during the national government, we used to have the district development officers in each and every district, where they would correct information, also they estimate the information of the government in those. So now, since we have not spread the wings to the sub-counties, but we can still have those notice board, suggestion box, or complaint box, where we will be receiving our news from the people from our side. There was a question that was not answered about the procurement. Dr. Sisi, she has answered about the process of preparing BQs, how we intend to handle that issue by increasing personnel in that department. But also note that according to the presidential order number 2 of end-to-end procurement, we still have a teething problem, starting from our procurement officers down to the merchants. How many people, if you set that order in the IPMIS portal, how many people are receiving that order or returning the order? The uptake of the E2E procurement process still have some teething problem that might affect the budget absorption in the county. Not that we have not trained our procurement officer, but still, are the merchants who are supposed to do the work, are they trained? As you continue now training our procurement officer, because it's a new system. So to address the teething problem. But on the other hand, with the treasury fully trained the merchant out there, I think we call it 2 trainings. And you see like the road contractors ni wazee, wengine they don't have mtu wa mkono wa kufanyia hiyo kazi. He was used to fill the BQs, hard copy. Now I want them to fill the system and return within 14 days. If you fail to return within 14 days, it expires automatically. But previously, it would even extend. But now if you put the system to extend it, you have to give the reasons. So, and there is a system, so you still have some grace in the procurement process. Thank you. Unless somebody have a question, that's how the Department of Economic Planning intend to be involved in the public participation.
Thank you very much for that. Not unless there's any question or inputs. Yes.
Mine is a small concern. You mentioned about the procuring, or you're thinking of having these boats at sub-county level. How effective do you think that will be for the consumption of Wajiko, whose movement is from the village unit to maybe to the shopping center, which is the sub-location level?
Okay, one, the documents or the document, we have already put them in the website, or they'll be available in the website. Now we are moving further, rather than concentrating on only being in the headquarters, we are moving down to the sub-county where you have ward admins and sub-county administrators. Still, it's just a step forward, rather than staying the way you used. The only nation can come in the office and ask those documents. Now they can be available somewhere else. It's just our step. That's our starting step.
Thank you. Now, how you mentioned the what that means? So you make best use of what it means, and whenever they are housed at the DO's office or the assistant chief's office or chief's office, whereby it is more closer to Wajiko rather than the sub-county level, as you have mentioned.
That's what I'm saying. It is the starting point.
Okay.
So I have maybe 2 questions. One, because now health is free and you used to make a lot of money from health in your local revenue. So how does that affect our budget? So will we see a change? Number 2, because the CRA, Commission on Revenue Allocation, they punish any county that lowers its local revenue. Then number 3 is always the question I ask about the conditional grant for level 5 and why the county views it as not conditional for that facility but just money because we host that facility.
I'll start with the conditional grant. The allocation that you won't say that for PGS, county referral, but if you say that the 407 is only for county referral, what about the salary of those people that are there? If you initially, or we say holistically, you give it more than the 407. So why should you now condition to give that amount 407 specifically go to the hospital, or like the Madam Doctor she said, yeah? If there is no money, you can say that this is the USC money, this is conditional grant money, or like for the county referral. That money goes to the health sector. We allocated the health sector and then distributed there. And if you measure the amount of funds that go to the county referral, it's more than that for 407. The question was?
Now you expect lower
revenue, yeah. But that there's still the amount that we are receiving on USC. You still consider it as our in when budgeting as a source of income.
But not local revenue.
But not local revenue. They can also not punish us because, like, previously we used to charge 20 shilling, but then they brought the user fees for gone fund. But now the counties were not punished for not charging that amount because it's like you are lessening the burden to the mwananchi. So I don't think they will still punish us for not correcting that fund. But still, those people who come outside the county are still charged the money at the PGs.
Are still paying, yeah.
Yeah, they are still paying. So it's just a proportion of the fund. It's not all the thing that we used to correct there.
I want to invite the Auditor General just to say a word, and then we'll continue from there. Karibu.
I want first of all to say this is a learning process because we are sharing knowledge, and ours is just to give an overview of what we require from the citizens and those who are governing the institutions. The mandate of the Auditor General is to audit all public institutions that receives money from the consolidated fund, or they collect revenue on behalf of the citizens to provide services. One of them is the counties. We have also the national government. We have also the commissions. We have CDFs, water companies, universities, and so many other. It's a statutory report that we produce every year. Every financial year we produce a report and submit to the National Assembly, the Senate, and the county assemblies. So these reports actually are taken to the oversight bodies, that is the National Assembly, the Senate, and the county assemblies. The reports are actually shared and publicized after they have been tabled, so it's a public document. The statutory report highlights the issues that may be of concern to the auditor. And our reports actually are in standard form. That means we use standards to audit the institutions. There is a guiding principles or standards that we use to audit the institutions, and the report actually is based on those standards. So there are 4 reports that we issue. Some of you might, there's a report that has been issued. Maybe you have seen it's a qualified, so you're asking yourself, what is qualified? The worst report that we issue is a disclaimer. That report actually, when we are not able to form an opinion on the records and the process and operations of that institution, so that is the worst. Then we come to maybe number 3, that is an adverse report. The adverse report, there are issues, yes, but the financial statements are not okay. Then number 2, we have a qualified report, that is for Nyeri executive, and I think they have moved from adverse to qualified, so it means that they have improved. So there are small issues that they need to do to check so that we can have a clean report. So, and the first report now, which we consider it to be the best, is unqualified. So based on those reports we issue, then you can see where Nyeri County is, or any other county, because our reports are actually publicized. Because of the resources that we were getting from the national government, we know resources are not enough. Previously, we were taking about 6 to 9 months to issue a report. But now it has, not 6, but about 9 to in the office and also the citizens. Because our office is a public office. We have the citizens. And when that report actually comes to you, do you really understand that? You may ask yourself, what is a qualified report. The Auditor General is in process, Office of the Auditor General is in process of trying to have reports which are in Kiswahili. When we, in fact, it is soon we'll try to translate those reports to a language that Mwananchi can understand, so that you can interrogate ourselves what we are reporting and what you are seeing on the ground. Because actually, if you can be able to understand that report, you participate and you have an information that will assist you in questioning those who are in governance. We have been asked also to note on the issue of the civil society organization. What are we doing between ourselves and the civil society? Because this is we are serving the same citizens. We are working on, the Auditor General's office is working on a framework so that we can have a link between the civil society, because they are also the oversight of the citizens, so that that information can come to us in a more, maybe we can have a collaborative nature, so that we can outsource some of monitoring of these projects. We know the Constitution actually demands that there should be participatory implementation of projects. You cannot just impose on the citizens. The civil society comes in to assist in monitoring of these projects, because actually they are on the ground. Ours, we may be, we are found maybe serving about 5 counties now. But the civil society can be able to drill down to that information at the lowest level. So we want to, the office is working on that framework so that we collaborate. Because actually the social accountability is about the citizens themselves, taking those who are in governance, answering, to be answerable on their actions. You ask them, we gave you this mandate. How are you used the resources that you have been allocated? The issues that come up, I want also to talk on the issues that we normally come up we report on. And over the years, the counties have improved. And that one, it has been, since 2013, the reports actually have moved from disclaimer. Most of them, they were in a disclaimer because of the capacity and the rest, and capacity issues of maybe information. But the performance of the counties have actually improved over time. And for the first time, we have about 2 reports for the county executives which are unqualified, and about 5 or so which are on the disclaimer side. So that is a parameter that shows, it's an indication that we have improved from that time that we, the inception of the counties to today. The reports that we issue, if you look at the reports, the first part is on the figures in the financial statements. But we want to move from that part of the figures to the use of the resources, whether they have been used lawfully and in an effective way. You may say that you use 100 shillings to, or let's say 1 million to tarmac a kilometer of road. Somebody else has used 500,000 to tarmac the same distance. So who is more effective? It depends on the parameters that are there. So our reports actually in future will be on the effectiveness, lawfulness, and equity. Because actually, if we don't actually talk of equity again, then of course we will not be able to report to the citizens on the impact of the resources. Another issue that comes up on our reports is on governance. We want to put to task those who have responsibility of governing the institutions. How have they used that position to serve the citizens? So in that, have you used the resources wastefully or in an economic way? So that you don't actually have to put probably 2 health centers in the same location, or you are building a maternity in the same location where there is also another one which has not been used. I think that will be a waste of resources, and you are not using the resources effectively. So we endeavor that the civil societies will actually engage with us after we have developed that framework, so that we collaborate with the civil societies, because ours is an independent reporting. Over the years also we have improved on our processes. We have automated the audit process. Nowadays, the reports are in soft form. That means those people who actually do reporting must actually be computer literate. You cannot just come to an office and then do a report. We expect that all of us who are in the office of the Auditor General will actually be able to use the IT to serve. Like the issue of e-procurement. If you are not IT savvy, you will not be able to interrogate the processes that have been used in procurement of goods and services. Budgeting is also an issue that comes up every now and then in our reporting. How have you used the resources that was actually approved by the County Assembly or the national government to the executive to provide services and also provide goods? As the report has been the report that has been launched, they have indicated the budget amount and the amount that actually has been spent. That is a tool that we also use in our office, because the budget itself is a control. Those people who have been given resources, you have told them, we are giving you 2 million to build a road. If they spend 5 million, they will have to explain why it went up from 2 million to 5 million. If they are not able to explain, then of course they do not actually follow the law. So such issues actually come up in our audit when we are doing the audit. But we are happy that Nyeri County, even though there is room for improvement, the reports, maybe there are about 2 or 3 issues that, or projects that maybe they were spent. But overspending is not illegal. But once you are on the ground and you are able to explain why it went overboard, then of course that is not actually illegal. So as long as you have followed the process and actually you have been able to explain the reasons why you overspent. Citizens are demanding for accountability and transparency. Even in our office, we are opening up. Previously, the reports were actually to the ministry or the parliament alone. And when it comes out in the press also, that is a way of the openness and transparency that we want. So that you know your people or those who have been put in charge of the governance to explain to you how they have actually used the resources. So in our office, in future, we would try to have public forums so that we can engage with the public on the reports. When there is availability of information, then of course you can be able to engage. That we will explore, and also for the first time in 2015, the Auditor General actually presented the reports in Parliament, but because of some challenges that we have there, we expect that in future we'll be able to present the report in the county assemblies so that the citizens can come to get the reports themselves. Otherwise, I want to say thank you for the collaboration that we have had, and this is a good starting point that we want to engage with the citizen and also the civil society, because we cannot actually talk or be in one place, all of us, but we use the structures that are there so that we get information.
My task is just to give vote of thanks, and I'll start with Heraf, because it is through them that we have been able to converge here to discuss what we have been discussing all the day. And through Heraf, we have done a lot of advocacy at the grassroots, so we are very thankful to them. And again, we will also extend our thanks to SIPE, Center for International Private Enterprise, because they are supporting Heraf to do what we have been doing. Those of you who remember when we started this journey sometime last year, it has been a lengthy and demanding process that, thanks to God, that finally we have come to the culmination. Then I would also like to thank in a special way all those people who took part in the study. Personally, I went to Amagana Health Center for 2 days. We were in a bigger team. You bear witness that among all those who are with us that time, we spent at least 2 days going across the county to collect information, to collect data that has been presented today. Then I would also like to thank the coalition, Nyeri County Budget Coalition. It was a brainchild of Heraf. We came together several civil society organizations who are working within Nyeri. We decided to pull together our effort to create synergy and to see how best we can serve our county. We are not going against anyone. We only try to put our efforts in one basket so that we can move forward and see what we can do for our county. Not necessarily making noise that the county is not doing 1, 2, 3, but we also have a role to play. That's what we have been doing in this coalition. I'm a member of that coalition, and I'm also a co-chair with another person from Heraf. Then, in a special way, I want to thank the county government representatives who are here with us and those who are still with us. You know, they are busy like anybody else, but they decided to come today and be with us to own the process. They have been back and forth between Heraf, the coalition, and the county officials, demanding for this report, demanding for this information, asking for their guidance and assistance. And at one point I was sent to procurement office to fight for those files and to mine data. And I did it for 2 days. So we thank them for giving that opportunity to us. That transparency means a lot. We can now speak on their behalf. Tunaweza watetea. They are very clean because they facilitated what you wanted. We also thank CHMT. Can see Chief Officer is still with us. The Director, I have seen him. Yeah, the CEC was here, and other people who are in the health sector. Thanks for finding time to work with us and being with us today. I would also like to thank the Economic and Finance Department, the Procurement, the Auditor General, and the rest who found time, and they are still with us up to this time. Then there is this team, the committee of experts. Yeah, the expert who sat down after we collected data, we gave it to them. Yeah, they collected data, they interpreted, then it was presented to us. Maybe they are not in this room, maybe they are. Those people who did that, Catriona, I can see her, Ajuru was here, Jemima, I can't see her, George, and the rest. They sat down, they collected data, interpreted, and now it's easy for all of us to digest and even to explain to others. Special thanks to all of them for their effort. Finally, I can see other people, I don't know where to categorize them, the media people. Thanks for being with us. We hope all what have been said in this hall, we are going to represent it out there and we are going to read it from the print media. So I take this opportunity to say thank you to each and every one of us for finding time to come here and be with us. You have not mentioned you in any of the above categories. Still receive my thanks because you are very important in our coalition. Once again, let me say I'm a member and a chair, but I work with Kenya AIDS NGO Consortium, CANCO, here in town. We are going to welcome you again and again, maybe to discuss other issues outside what Heraf is discussing. But that's a story for another day. Finally, I want to give thanks to God for the opportunity He has granted to all of us. True or false? True. Yes, we owe Him a lot. But I'm only going to say a few things. We are very happy because today was the day to launch this report. God has been faithful all through. He has walked with us. I remember some facilities were very far. Is it Mothangira? Yeah, even I couldn't trace it in map of Nyeri. Even now I don't know where it is. But one of us went there and came back with data through the mercy of God.